I welcome all of you for today's CME on rheumatology. For today's CME, we have a renowned speaker, Dr. Vijay sir. Is practicing in Mumbai. To introduce him, I request Dr. Madhusudan. Please give introduction.
Good morning, one and all. For today's CME on rheumatology, we have as a speaker with us Dr. Vijay Viswanathan sir. He has done his DCH, DNB, and after that postdoctoral fellowship in pediatric rheumatology from University of Western Australia. He is a consultant pediatric rheumatologist in Jupiter Hospital, Thane. Also, he is a chairperson of Pediatric Rheumatology Society of India. He has multiple publications in index journals. He has also wrote chapters in textbooks and more than 100 oral presentations in various state and national meets. So, I welcome Dr. Vijay Viswanathan sir.
Kind introduction, and I thank Dr. Lokhande, Dr. Vikram, Dr. Atul, and all of you. After Chennai Super Kings getting knocked out, this is the next bad news for all of you guys, because you're stuck in this room for the next 4 hours, maybe 5 hours, maybe 6 hours. So the first warning that comes is I have got only 207 slides. So जिसको भागने का है अभी भाग जाओ, नहीं तो बाहर हम लोग ने एक सिक्योरिटी रखा है to lock the rooms. So it's going to be like a big boss story, but I'll try to make it not very toxic or intoxicating. We'll try to go very, very clinical, and it's not going to be a very serious 90, 100-year-old professor emeritus ka lecture with evidence-based medicine and criteria, etc., etc. We are just going to talk day-to-day scenarios, and I am almost sure that one of you is going to see a child with a joint swelling tomorrow morning in your OPD. So what to do, right? So this is one slide which I always like. जब लाइफ में दुख होता है कि मैं खाली बैठा हूँ, और ज़्यादा दुख होती है जब सामने वाले के पास बहुत सारा पेशेंट आता है. So one rheumatologist wrote this article from the US, and he conducted a study on which is the happiest subspecialty or specialty in medicine. And the result was very obvious. I think the last benchers can see, because they are the ones who probably might be the next pediatric rheumatologists. So rheumatologists came across as the happiest human beings, and to know the reason, you'll have to stick on till the last slide. So how many of you are students here, other than Dr. Atul Kulkarni and Dr. Vikram and Dr. Lokhande and the first benches, who are PG students, who have not passed the exams? 1, 2, 3, 4, 5, 6, 7. So thank you for raising your hands. You are going to be my target audience for today. So all questions will come to you. Pediatricians need not feel bad, because they are not at the end. At the end there is internal medicine. So pediatricians are somewhere midways. So 1, 2, 3, 4, 5, 6. Right? So 6 is not bad, right? So I was thinking, what should I teach Solapur, because I think of all the states in Maharashtra, Solapur is probably second on top when it comes to rheumatology referrals. So I think people here are quite smart and cerebral, and I think there is quite a lot of similarities also. So let's start with this 1876. I'm just showing you a few filling slides so that more people can walk in, and we'll kick off in about 10 minutes time. I got to know that a lot of things are similar between Solapur and rheumatology. So 1876 was the time when Solapur, when those division was happening. So one subdivision got added. I think it starts with an M. That's the maximum I can remember preparing for this talk. Mashila. That became a part of Solapur subdivision. Correct, Mahalshiras, 1875, whereas in 1875-76, one chemist from UK found out that salicylic acid is the drug of choice for rheumatic fever. And I was just mentioning outside that as a kid, traveling to Chennai in Chennai Express, we always used to know that Solapur is one station जे अस्तित्वात आहे पण कधी दिसत नाही कारण ते सकाळी 4-5 वाजता येतो. And we never saw Solapur station. I think rheumatology is very similar. Rheumatology is also present in the textbooks, but as a PG student, you hardly, you just go through it or you probably never read it. Or at least that used to be the situation when we were students. Very peculiarly, 11 talukas in Solapur and 16 villages. How many of the PGs know this? Sola, I was wondering what is Sola in Solapur. So that initially the Solapur was made of 16 villages. Adilpur, Ahmedpur, बाकी का तुम लोग ढूंढ लो, right? Gen Z, how all of your Gen Zs after 2000 or just about knocking at 2000. The generation which uses iPad but doesn't know how to tie the shoelaces. ऐसा मैं सुना है. And rheumatology is just about 11 diseases which we will be covering in the next few hours, and you will see that when you send an ANA blot, you will have 16 antigens. So there's quite a bit of similarity. The culture and traditions, I think, are also quite interesting. Rheumat existed even in Egyptian mummies. People have found out that even those mummies had evidence of rheumatoid arthritis. So it's been existing for hundreds of years. And how many of you know that Solapur was the first place in the country to celebrate 3 days of independence even before Independence Day? You will go and find it out, because turns out that people who were pro-Gandhians were fighting against the British, and the Indian public, when Gandhiji was arrested, started destroying police stations, etc. And then the British gave the command of Solapur to the local Congress party leader. And somewhere in 1930, 3 days of non-British rule existed till sanity came back. It's quite interesting, I think most of you are looking very happy and satisfied. That's what I feel. I am very happy coming out of Mumbai for the weekend. And the last similarity is, I think both rheumatology and Solapur would probably start off with inflammatory beginnings. These are the things which are my to-do list, Sangam Vada was one which your president did not take me out to yesterday, but has promised me today. I didn't know Mirchi Vada is equally famous in Solapur. But like in rheumatology, what starts very angry often ends to be very sweet. So I want to go and see Appa Halwai and Yana. How many of the PGs visit these places? How many of the PGs know Katta Corner? Katta Chart Corner? None of them. Nice. Perfect. So coming to today's programs, this rheumatology training module, or rhythm as I called it, was a part of my presidential story during the last year, and the idea was to try and take the basic rheumatology sessions to the grassroots and the corners of the country. And we know quite a bit of rheumatology, but it was just a matter of the guys who don't know would probably be sensitized, and the people who know a bit will take that knowledge to the next level. And it's a good idea to keep revising it. I think Rahul Gandhi started the Bharat Jodo Yatra at around the same time. I am not Rahul Gandhi, so you don't make any judgments. I call it Rheumat Jodo Yatra. And it's been a fascinating journey. So it started off with, you may think that this is a Mercedes or a limousine, this was my first CME in Dibrugarh, and this was actually a friend's Alto K100. The PGs are already making a very bad face. Alto? Okay, that's how the rheumatologist gets for going around the country. But it's quite a scenic place. And this is one photo which will remain with me for the rest of my life. So people thought I'm going to Srinagar to enjoy a holiday, but this was the car which came and received me at Srinagar airport. Can you recognize the car? It was launched at the same year you guys were born. It was a Maruti Omni Eco with a Sarkari ambulance car with a headlight also. So the program happened in the government college, and they sent me a patient ka ambulance to receive me. It was quite touching, to say the least, and that was the best program. The hall was full, and imagine in a place like Srinagar, everyone, including POK, had come for the meeting, which was quite interesting. And then the story kept moving on. Which place is this? Goa. So you get to eat also. And the best car I got was, this was my car actually. Where is this place? This is Solapur. This is the last night's meal. And I think that we did around 8 programs last year, and 8 programs I have made about 30 new friends, and I got a chance to help out 10 kids from these places. So Durg Bhilai, Dibrugarh, Guwahati, Rajasthan, Jaipur, Navi Mumbai, Kochi. And once you start telling the pediatricians, they start recognizing this, and we've cured kids with PAN, dermatomyositis, etc. on phone, thanks to the sensitization part of it, right? So let's start with our usual business. I always like to start with what are the myths and in rheumatology. The myth is rheumatology is rare. ESR is very, very non-specific. Whereas the truth is 1 in 250 kids have some form of JIA. ESR is hardly done. Even the pathologist is not interested in sucking the blood and putting it in a tube. But the importance I'll teach you in the subsequent slides. Rheumatology is not about expensive tests or packages of antibodies, etc. It's purely clinical, followed by a good examination and just a few tests if needed to confirm. It's not a depressing branch. It's one of the branches which is exciting, challenging. Always you are cerebrally thinking about what's happening. The best thing is you can't write nil rheumatology and sign off. Every other branch can probably write nil neurology, nil surgical and get away. I can't do so. One of my friends keeps joking ki, and I have a problem. Whenever I go on a leave, when I sign the leave form, who's my locum? There is no one else. One of you guys can, right? But then Jitendra Gawane is one of our close friends who keeps saying, "Tu gaya to tera locum is methyl prednisolone." I said, fine, fair enough. But then it's true, but we don't give steroids without a rationale. We kind of prove something and then give the steroids. We'll cover the steroids part also. So coming to numbers, why are you guys here and why am I here in Solapur, right? So as I said, the prevalence of JIA is 1 to 4 in 1,000, which means there are some studies which says even 1 in 250. If you take 4 in 1,000, you will probably think 1 in 250 kids has some form of JIA. And I'm not even using other forms of arthritis or rheumatology. So I just did a quick search and found out Solapur has a population of 4.3 million in the last census, and of which about 50 lakhs are children. And out of this, if you extrapolate the data, you will still be having at least 300 to 600 kids with oligo JIA alone. 50 lakh children below 6 years, right? I have probably seen 15 kids of JIA from Solapur in the last 15 years. And we are about 3.5 pediatric rheumatologists in Maharashtra. Still, I think the numbers are skewed. Where are the others? Either they are not getting diagnosed, or they are with the adult orthos, or they are with someone else, right? So there are the numbers which I'll show you over the few slides. And obviously, the need is, if I just put this data, Solapur itself needs a minimum of 3 pediatric rheumatologists. By pediatric rheumatologist, I mean the one who doesn't see adults, and the one who doesn't give vaccines, and the one who doesn't attend every CME on Sundays. So the numbers, and there is a definite need for people like us. Why is this? Because there are unique issues why an adult cannot treat pediatric patients. we have unique issues which the adult rheumats don't encounter. Growth and development issues for a start, like we don't need to bother about marriage, boyfriend, breakups, pregnancy, etc., etc. The same genetic type will have varied phenotypes. Some diseases do not exist in adults. Kawasaki disease, for example, is an exclusive pediatric proposition. Juvenile oligoarthritis does not happen in adults. Gout doesn't happen in children, so on and so forth, right? And understanding the pain, the use of anti-rheumatic drugs, how to deal with parents, the schooling issues, and we have to ensure a smooth transition into adulthood. Enough of the boring stuff. Let's start with, actual signs. I think we can lock the doors now. So these are two kids. Both these kids were referred to me as JRA. How many of you think these kids are sick or happy? Are these kids happy or sick? Sick, hands up. Okay. How many of you think these are JIAs or JRAs? Which one is a JRA? Your this is my this. the white kid or the one in Nasik? Why do you think this is Nasik? राक्षभाग दिसतंय ना. हा तो एक्सरे लंगमध्ये लंग शिवाय बाकी पण दिसतं, ते बघायचं. दॅट्स द वे rheumatology works. See what's happening around also. And this kid actually helped me by giving us a hint also. He was wearing a t-shirt which said JRA. Do you think this boy is JRA? So first thing is, there is nothing called JRA. It's always JIA, correct? And then don't go by a t-shirt. आंबेडकर सरांनी शिकवलंय ना, बाळाकडे बघा. बघणं is translated to English is seeing. So Amdekar sir has done the hard work teaching us to see at the patient or see the patient. What I'm going to tell you in the next 3 hours is to start looking, right? And there is a saying, no, दिसतो तसा नसतो. आणि त्यातच निदान असतो इज रुमॅटॉलॉजी व्हर्जन. म्हणून जग फसतो, आपल्याला नाही फसायचं आहे. पण जे दिसतो ना, स्टॉप सीइंग अँड स्टार्ट लुकिंग, बिकॉज आय विल टेल यू व्हॉट हॅपन टू दीज टू किड्स in the subsequent lectures, subsequent slides, correct? So when do I suspect rheumatology in a day-to-day practice, right? Always. And the common 4 situations are acute arthritis, chronic arthritis, multi-system inflammatory backdrop, vasculitis, and PUO is probably the commonest referrals that I get. We will probably just touch upon the others if time permitted. And to the untrained eye, all the joints will look the same. And hopefully, by the end of the next 3 to 4 hours, you will start noticing some subtle differences. And you will be able to make sure that this is JI, this is something else, this is lupus. And what I am hinting at it as, the Rakshabhag Disla Tasa, start recognizing patterns. And what we are going to discuss very slowly is how to pick up the patterns. हे पॅटर्न आहे, हे आर्थरायटिस आहे. शेंगा चटणी दिसली, इट इज सोलापूर. अख्खा मसूर दिसला, इट इज कोल्हापूर. सो ऑन अँड सो फोर्थ. So stop seeing and start looking. So let's start with the basics. Arthralgia does not mean arthritis always. First basic rule. What is arthritis? You need to have a triad of pain, swelling, and restriction of movements. For understanding purposes, let's keep acute arthritis as less than 2 weeks, subacute as 2 to 6 weeks, chronic as more than 6 weeks. Rule number 2 is acute arthritis is, as a rule, always pain more than swelling. Remember, the chronic arthritis, the problem is in the synovium, so there will be swelling more than pain. This is pain more than swelling. And then you have the ICICI that Dr. Amdekar has already taught us: infection, malignancy, collagen, coagulopathy, and idiopathic at the end of it. Then once you know this basic, the next question you will answer is, where is the pain coming from? Is it coming from articular or periarticular? So like we know, the articular structures include the synovium, the cartilage, the joint capsule, whereas outside the joint you have tendon, bursa, ligaments, bone, etc. The articular pain is very deep and diffuse, whereas the extra articular is very, very focal and it is more painful. The pain in an articular involvement is in both active and passive, whereas periarticular will generally be painful only when you actively just keep moving the easiest way to differentiate is, remember, P for periarticular and P for pain. When there is a lot more pain than the swelling, you may think it is coming from the bones or the outside the joint. I'll show you through cases. And remember, S for synovitis and S for synovium, S for swelling. So the intra-articular ones will always have a swelling, whereas the extra-articular ones will have lot more pain. So P pain, P periarticular, S swelling, S synovitis. Easy. Once you have done that, we will form a nice sentence using each one of these criteria. This is the most basic slide which all of you have to carry home. Age, gender, sick versus non-sick, acute, subacute, chronic, large, small joints, upper extremity, lower extremity joints, central or axial involvement, morning stiffness versus nocturnal pains. If there is a multiple joint involvement, additive versus fleeting, and are there any systemic features like fever, hair loss, skin rashes, skin tightening, Raynaud's phenomenon, muscle weakness, etc., etc. So once we know all this, people who are walking in late are going to go home late also. 3 people who have just walked in. So once you answer this question, just put it in one sentence. Like age, gender, so you start with a 2-year-old girl, happy, non-toxic, acute, subacute, chronic, we know, right ankle and right knee with morning stiffness, additive involvement with no systemic symptoms. Once you frame this sentence, put it to ChatGPT or Gemini or whatever, it will give you the answer. Refer to Vijay Viswanathan or refer to rheumatologist. Or sometime it will say, I don't understand what you say. Sometimes it will say juvenile oligoarthritis. The key is, make a habit of breaking the things into small things, and one joint, it will take you hardly 5 minutes to frame this sentence. And then with experience you will realize what way we are supposed to follow. So why this first slide is because morning stiffness is inflammatory. Always the most uneducated patient will say, Sakali uttanna gaadi start hot nahi. Morning stiffness is a history which all of you have to ask. And paradoxically, nocturnal pains, you will have to be, it can either be a malignancy or it could be a simple mechanical growing pains like story, right? Who will answer me, why do you get morning stiffness in JIA and nocturnal pains in a malignancy? Think about it. We'll try and answer that in the break because it's actually a gold medal question, right? Any pain which gets better with rest is mechanical, which gets better on activity is inflammatory. So child who's very stiff in the mornings doesn't want to get down. By child I mean not a PG student who will also be reluctant to get out of bed in the morning after a night duty. But the minute you start walking more, you feel better. That is inflammatory or JIA, right? The pain which gets better by resting is usually a mechanical pain. Lower extremities very typically in rheumatology are a part of reactive or reiters, as we will see. Acute rheumatic fever, you still see a few here and there, though the numbers are less. Septic arthritis, osteomyelitis generally affect the lower extremities. And last but not the least, chronic arthritis, ERAs are all the B27 type disorders are generally lower extremity joints. Upper and lower is could be anything. We will skip that for now. The spine is very, very important for the pediatrician. A child who comes with severe backache, severe backache, you just need to do an ESR 120, do an MRI, you will find TB or malignancy. ESR 20 and severe backache, send them to the physiotherapist. Usually the rule, it's a mechanical pain. But do not label a child with a spine as HLA B27. That's the commonest mistake we will do. Spine आया तो B27 नहीं. It starts from the periphery, as we will see. So it's more about take the detailed history, and you will find the answer in the first few. Most of the spines which doesn't get better with rest, might end up with something sinister. Additive and migratory. All of us know the causes of migratory arthritis. PGs, don't look at the screen and tell me. Migratory or fleeting arthritis. Suggestive of? I can't hear you. Loudly, loudly, loud. Which years are you in? Third year? Second year? You guys are medical students only, no? No, I'm just kidding. वो ऑडियंस के लिए बिल्डिंग के 3-4 लोगों को आके बिठा दिया होगा, नहीं तो दिखना चाहिए हॉल फुल. व्हाट्स द कॉमनेस्ट कॉज ऑफ माइग्रेटरी आर्थराइटिस? लाउडली, आई कांट हियर यू. यू आर करेक्ट. आई वोंट बी योर DNB एग्जामिनर, डोंट वरी. रूमेटॉइड नहीं, रूमैटिक फीवर, correct, is migratory, fleeting, large and usually the large joints, right? Additive involvement is a more common problem which needs to be addressed. But one differential for migratory or fleeting is a leukemia. Remember, leukemic pains can also fleet. So let's move to some case scenarios, right? 5-year-old girl who has high fever, rhinorrhea, some rash, malaise, first OPD tomorrow morning. काहीतरी व्हायरस आहे, पॅरासिटामॉल घ्या, घरी गेली, बरं झालं, 2 आठवड्यानंतर गुडघा सुजून आली. अँड नाऊ वी नो दॅट यू आर गोइंग टू आस्क फॉर अ हिस्ट्री ऑफ मॉर्निंग स्टिफनेस. हो, सकाळी सकाळी पाय सुजलाय आणि खूप दुखते. अँड यू डू अ बेसिक CBC अँड अ CRP and an ESR. So I have 10 pens which are magical pens, which from tomorrow it will not stop till if you start CBC, unless you finish CRP, ESR, SGPT, creatinine, it will never stop. It will be going into status Rheumatology or whatever. The benefits of ESR and CRP I'll teach you in the subsequent slides, but remember, never do a CBC alone because you will be lost. This is a normal CRP and CBC. ESR is slightly high. What's the diagnosis? So reactive or post-infectious, right? Most common situation. Now, from a 5-year-old, if you have a 11-year-old boy who comes with additive swelling of left knee and right ankle, so it's not fleeting or migratory, it is adding up, and there is a history of morning stiffness, so it is inflammatory. The child has red eyes since 1 week, and then this is actually a true story, who went to Sri Lanka, had some food poisoning, dysentery, and comes back with joints and conjunctivitis, and he's got a corneal opacity also. And you do the blood test, and as a habit we do CBC urine routine. Urine में 15 pus cells भी आ गया, and this child came to me with Septic. What's the diagnosis? Reiter syndrome, right? No brains needed for this. Who was Reiter? You need brains for that. Do we still call it Reiter? We don't call it Reiters anymore, because Reiter was a soldier in Hitler's army who used to be involved with a lot of experiments on human beings. So this is the actual textbook definition of reactive arthritis is Reiters. The first situation we use these terms loosely, but the first one we'll call it post-infectious or post-viral. This is very typically following which infections cause Reiter? Sorry? Gonococcal is perfect. Something which is more pediatric friendly. E. coli, Shigella, dysentery, Campylobacter, etc. Correct? And reiter, so 15 pus cells is because of urethritis and not UTI. What is sterile pyuria? More than 5 cells in the urine in a centrifuged sample and more than 10 cells in a non-centrifuged sample. So एक तो यूरिन मत भेजो, अगर भेजा तो उसको इंटरप्रेट करने को आना चाहिए. So 10-15 pus cells. So this is urethritis, conjunctivitis and arthritis. You may not need all the three to fulfill the list, but this is a very typical situation for a reiter syndrome. What's the third one? It's a very easy thing. We can keep moving fast in the early slides. 5-year-old boy, very typically in Bombay, you will have these kids on Saturday because they will be on the trampoline jumping. Orthos are in Lonavala, Matheran having a CME / educational trip. And the pediatrician in the casualty will see this 5-year-old boy who's limping very badly in one leg. And you just move the hips and this child has severe hip synovitis. What's the diagnosis? And blood test is essentially okay. Transient synovitis of the hip, very nice, right? So common 3 situations which can come with acute arthritis is these 3, right? The only thing is transient synovitis, if you have a 2-year-old with this kind of a history, is there a very close differential? A 2-year-old with one hip joint effusion with high fever, you should always rule out septic arthritis. The age-old saying, do not let sun set on pus in the hip joint. Hip joint, always do a CBC, CRP, ESR, and you have something called Kocher's criteria. A CRP which is high, an ESR which is more than 40, a WBC count which is more than 14,000, and if the child has fever and non-weight bearing. If all the 4 are there, chances of it being septic is 90%. If 3, then 70%, etc., etc. So remember, if you are in a doubt, please do a CBC, ESR, CRP and correlate with the fever and non-weight bearing history. If all the reports are like this, send the child home on naproxen. Monday morning, this child will get you a piece of cake. आता एकदम magic झाला, पळायला लागली. But if you send a child with septic arthritis on naproxen, Monday morning you will be in trouble, right? So the clues are, most of these kids are not sick. It's a short history. Blood work is essentially normal and it's very, very clinically recognizable. What's this? The 4th situation. This is a girl, I think last month we all celebrated strawberries, grapes. Red used to be the favorite color of many pediatricians, I think. This is a girl who you open the mouth and see tonsillar follicles. You gave augmentin, amoxicillin for 7 days. Child got better. And 10 days later, she comes back with painful, additive, large and small joints with morning stiffness. So what do I mean by that? This is inflammatory following a bacterial tonsillitis. And you do the blood test and the ASO titer comes very high. Is this rheumatic fever? How many say it is rheumatic fever? One came. Sir, why do you think the others are saying no to rheumatic fever? What's the clue in this? Correct. Even this has come after 10 days, no? So it's a short incubation, right? Rheumatic fever is usually 3 weeks onwards. This is only 10 days. Rheumatic fever is migratory. This is additive. Rheumatic fever, obviously the other criteria aren't fulfilled. And then you generally don't get these small digits, fingers, etc. Right? So this is a unique post-infectious disease called post-streptococcal reactive arthritis, which some people think is a form of rheumatic fever. So you will still end up doing an echo in this child. Make sure that there is no carditis, etc. Right? And then put this child on naproxen or intra-articular injections. So differentiating ARF from PSRA is equally important. Now, the last situation is, this is just a picture to, so usually the reiters will have conjunctivitis, whereas this child actually had a, if you can appreciate, a corneal opacity at 9 o'clock. and then they can have monoarticular, and then remember how to interpret sterile pyurias in this situation. This was another kid. In fact, these two kids came to back with, one was reactive oligo, the other was reactive poly. You can also see this corneal opacity with a short history. And you know what's this called? You have this for breakfast, no? What's this called? Sausage digits, also called dactylitis. So when you see fingers with dactylitis, you will think of reactive arthritis in an acute setting. Fingers, big toe, large and small joints is reactive. If you have the same finger in a chronic disease, you will think of psoriatic arthritis. I'll show it to you in chronic arthritis, right? So what's the first cause of acute arthritis in children is post-infectious. Like we saw, specific situations when it involves the hip, it is transient. Following a tonsil is PSRA. Following a GI-GU is retur. Primarily could be oligo or poly. Generally it's the lower extremities. Child is usually happy. More of pain, less of swelling, and most of them will settle down with NSAIDs. This is a second situation where a child can come with acute arthritis. A 5-year-old girl comes with high fever for 7 days, swollen right knee joint with pain and limp. There is some trivial trauma. History of severe eczemas and pyoderma since infancy. And then when you examine, this is a hot, swollen, painful, tender joint. No specific morning stiffness, it's exclusively, excruciatingly tender throughout the day. What's this? Septic arthritis, no brainer, right? Quickly we will move on. Never ask for history of trauma. You can't fall one day and develop this swelling after 7 days. As a rule, kids keep on falling for a living. So you never ask for a history of trauma or कालच पडलेला नाही, एक आठवडा अगोदर पडलेला. No. Unless you are a hemophiliac, you will never bleed into a joint, or the fall will never cause synovitis after 1 week, right? So it was just one of the things. Eczema is like your skin barrier is breached. So the natural protection that God has given us is not there. So it's easy for bugs like staph, etc. to enter the bloodstream. Like I said, you may get an history of eczema or recurrent infections or PIDs, etc. Because many conditions like Brutons, etc. will have predisposition to, inflammatory arthritis or septic arthritis in this situation. So never waste the patient's money on an X-ray or an ultrasound in this situation. The easiest thing to do is, if you don't have an ortho, stick a needle inside. With practice, get the fluid out. If it looks green, yellow, your diagnosis is sealed. Send it for a cell count, and an acute arthritis with cell count of more than 50,000 in the joint. The magic number you're looking at is 50,000 cells, pushes it more towards being septic. 20,000-30,000 is known in any of the other inflammatory stories. And then obviously you send the culture. Do not corrupt these cases with oral augmentin. I have seen orthopedicians give oral augmentin for what seems or what they deem to be septic, right? Do an MRI, most important. MRI will pick you marrow edema very, very early, right? So septic. We've talked about Kocher's criteria. Keep this in your head. If you have a young child with septic or query hip joint, do these 4 things and you will probably never regret missing a septic arthritis, right? So this kid actually got referred to me from a medical college. I am a pediatric resident from this medical college. We have a 9-year-old female who was jumping on the trampoline and acute onset pain since 7 days. She was last seen hopping at school, and the next day onwards the pain has started. And there is fever since 7 days. Pain relieved on ibuprofen, combiflam, no signs of inflammation. USG X-ray normal, and orthopedician has given a clean chit. तो बोला फिर मुझे क्यों रेफर कर रहे हो? because ortho said it's normal and we also feel it's normal. And this is the CBC and ESR. Ortho says that there is nil active. You think this child is normal? What's abnormal in this history? High ESR and high CRP. And what's wrong about the history? Fever, correct? So, but then joints are normal. The pain is in the right popliteal area and the joint is normal. Can you have a normal joint and severe pain? So the age-old training that we have been taught is problem कन्याकुमारी में है तो कश्मीर में ढूंढो सॉल्यूशन. कश्मीर तक जाने की ज़रूरत नहीं है, महाराष्ट्र में ढूंढो. What is Maharashtra? If knee is Kerala, so I asked him to do an MRI pelvis with both the hips, and this is what came out. Severe marrow edema, not just metaphysis but whole diaphyseal marrow edema, and this is nothing but acute osteomyelitis, correct? So do not disregard a pain in a 9-year-old girl whose exam going and preparing for an annual day. She will not feign a problem, and obviously the benefits of doing a CRP and an ESR together is always helpful, right? So septic arthritis can come to you in an acute setting, and it is an urgency which may become an emergency if you sit on it. You need a low threshold and a high index of suspicion, and always, if you are in doubt, aspirate the fluid and send it for counts and cultures. Imaging, please think of an MRI. Don't waste money on X-ray and an ultrasound with shadows, etc. If you are doing an ultrasound, ask the radiologist to just aspirate the fluid for you in the same setting, because that might be more beneficial than seeing just random echoes. There are situations where you may have sterile effusions. Remember, osteomyelitis is infection of which part of the bone? Metaphysis, diaphysis or epiphysis? PGs. M for myelitis, M for malignancies, M for metaphysis. So when you have a metaphyseal change, remember that the knee metaphysis is outside the synovium. So you may aspirate a sterile effusion, right? So you may aspirate a sterile effusion. Doesn't mean the child is not septic. The child may have osteomyelitis sitting up. Whereas in the hip, it's a paradox. The synovium is big and the metaphysis of the femur is inside the joint. So even if you find a septic arthritis, you may be dealing with an underlying osteomyelitis. Is it important? Is it OM or is it septic? It is. Osteomyelitis needs a prolonged at least 6 weeks of antibiotics, whereas septic you may get away with about 4 weeks of antibiotics. Do not treat any of this with oral antibiotics till the acute phase markers get out of the way, right? And in the younger child, I told you about Kocher's criteria. Not very specific, but it's a good screening thing so that you guys enjoy CMEs on Sunday while the child is popping naproxen on a Sunday. The third situation where you can get acute arthritis. This is a 5-year-old male. I got this phone call about 15 years back from a pediatrician in Kalyan. He said, 5 वर्षाचा आहे, अनडॉक्युमेंटेड आहे पण फीवर आहे, पॅलर दिसतोय थोडंसं, elbow and feet pain. Okay, and there is no morning stiffness. We all know now that morning stiffness विचारायचा असतो. And it was referred as oligo-JIA. And he came to me with these 3 CBCs and 1 CRP. I gave this doctor the pen, but I didn't give him the refill. So what's missing from this? ESR. Is the CBC normal? I should not have highlighted many things, but what's abnormal about a 5-year-old with this CBC? Excellent. Platelets are getting reduced and differentials. Correct. So unless you are an infant, you are not allowed to be lymphocytic. Less than 1 year, they are lymphocyte predominant. This is a 5-year-old with lymphocytes slightly high. And as a rule, I have stopped looking at HB. Indians universally have low HBs. Just focus on WBC and platelets is one way of thinking, and CRP is 1 plus doesn't make a difference, right? And obviously the joints which are involved, elbow is very rare in JIA. Feet in a 5-year-old again could be reactive, but it's just going on, and I don't like this low grade fevers, right? So there were some clues. And then we said कुछ समझ में नहीं आता है तो naproxen चालू करके देखते हैं. And the child was started on naproxen with query oligoarthritis with no relief. Fever chala gaya, but pain is still there. So this is how I received this kid. And this child, when you don't understand, revisit the history. And she said, डॉक्टर मेरा बच्चा स्विमिंग करता है, साइकिल भी चलाता है, लेकिन पाय टकत नहीं. And then the pain is almost throughout the day and just gets worse in the nights. Now does it strike a bell? So there is something sinister. And when you see the joint, it's more periarticular. So more pain, less swelling, and I'll show you what. So if this child comes to you, what will you do? What's the next column that you will have? Direct. एक CBC तो बनता है ना? CBC के साथ क्या भेजेगा? पेरिफेरल स्मीयर भेज देगा वो हेमेटो वाले का ड्राइवर का सैलरी भरने के लिए, but it may be normal. Perfect. And obviously what was missing was, now does this make a difference? This is what I asked for, and the ESR came as 110. So don't go by the absolute WBC counts or a peripheral smear. The reason why leukemics get into trouble is the blasts are there in the bone marrow, and that proliferation of the blasts causes bone pain. And by the time the blasts gets released in the bloodstream to get reflected in the peripheral smear, it will take months, right? So even if the peripheral smear is normal, you have to start from the site of crime, which is the bone marrow. And the ESR of 110 and the platelets are low. So ESR and platelets going in opposite direction is a problem always, right? And then you can further, this father calls me saying pain is worsening, kaitari kara. And as tempted as you to give steroids, this child has an additional ankle involvement and he just can't sleep in the nights. And then you do the LDH and uric acid, you will end up with a lot more clues and set him up for a bone marrow biopsy, correct? Remember, uric acid is never a problem in the pediatric age group. Even if a child comes with a single toe, do not diagnose gout. If a child has a high uric acid in pediatric age group, children never get gout. It is either a leukemia or someone on AKT gets uric acid high and joint involvement. Have you seen any of the kids on AKT getting crystalline synovitis? So rifampicin can cause gout-like picture, right? So uric acid is important, but not that important. Sure enough, this child had a bone marrow. This is a picture I keep seeing in Mumbai. Do you see such pics in Solapur? It's quite interesting, This is not the way you are supposed to ride. What am I trying to convey is, when counts are going in one direction and the CRP and ESR is going in opposite direction, you are heading towards trouble. In fact, yesterday on the way from Mumbai, I saw a small tempo with 3 cows. 2 were looking Aisa and one was staring at me saying, slow down, slow down, slow down. I didn't get time to upload the picture. When things are going in one direction, no, you don't bother. You may have 25,000 counts, platelets, you pray that 6 lakhs आएगा. 25,000 WBC में platelet 20,000 आया, you are worried. And 20,000 platelet में ESR 120 आया, this is not physiological. You are heading towards trouble. Please do not rely on the smear alone. Please get a marrow involved, right? So a normal smear does not mean no leukemia, rule number 1. And then white cells, platelets and ESR going in opposite direction is always an indication to do a marrow. And this is the picture which I want all of you to see. So this is how an articular swelling will look like. This is the joint lining. You can see this nice synovium jutting out, whereas this is a periarticular. So the whole feet looks thoda puffed up. So synovitis swelling, periarticular painful is more towards a malignancy. Right? So when you see articular, you diagnose JIA. When you see periarticular, you will see ALL, etc. Right? A very important clue. So what happened to this Draksha bug? So is he sick or is he happy? Sick. So this boy was very happily sitting in the father's laps, and he is the guy was very miserable. And as it turned out, I said it's Monday evening. You give him a tramadol and get him on Tuesday to see Dr. Nitin Shah. And in the morning, I saw this child. What am I trying to do? See what happens when I squeeze his feet. So this is severe bone pain, right? So don't, and this boy was actually, referred by an endocrinologist, a very clever friend of mine in Nasik, who said, this पैराथायरॉइड वगैरह सब आगे पीछे आया है, बट आई डोंट थिंक ही इज पैराथायरॉइड कैल्सीमिया, तेरे टाइप का कुछ तो है, एंड आई एम जस्ट सेंडिंग इट टू यू बिकॉज ही इज वेयरिंग अ टी शर्ट विच सेज DRA. So this child actually turned out to be a leukemia, right? So that's what I meant by, start looking for some clues, and you will get all the clues from a very good history. And this boy right now is, and he's not a very poor child. That Draksha bug is probably bigger than Solapur, but very, very sick child, and was roaming around for 3 months. So leukemia. This child was referred to me by a pediatric ortho. 8-year-old boy, severe polyarthralgia for 2 weeks. So could be any of the reactive things we have discussed. 2 आठवड्यापासून सगळे joints दुखतायत, low grade fevers, and he is so bad that he can't even walk. So that history of swimming, cycling but not walking is important because of non-weight bearing, etc. So unless you ask, you will never get the right history. The JIA kid will be happily running, limping, even jumping, but this painful kid will just not put the foot down. Why do you get leukemic pains in the night? I'm just reminding myself so that I don't forget to ask you later on. Unable to walk, counts are 4,200, platelets 90,000, ESR 120. And goes to the adult ortho who puts him on steroids, and despite steroids he goes to the pediatric ortho with lots of pain, and I get this call कि ये तेरे type का कुछ तो है, which is all that I want from pediatricians. Don't give me the diagnosis, give me the patient with a thought process. That's important. So what are the clues? Look at him. What is he showing you, and what are the reports showing you, and would you have given steroids? Puffiness of the eyes, excellent. What else? Is he able to walk? He's not able to walk also, right? And what's wrong with her WBCs and markers? Is it normal? Correct. So the trend is opposite directions. Platelets going down, ESR is 3 digits. So never start steroids in such child, so remember this picture. And then you do a head-to-toe examination. As pediatricians, we are always trained to look at the tonsils. What I am going to tell you is from today onwards, see the teeth, dentition, and look at the hard palate. The hard palate will follow in some time, but this child gave a clue on just opening the mouth. What am I trying to show you? Gingival hyperplasia. So what's the diagnosis? AML. Perfect. This is what it turned out to be, an AML. Correct? So it's very clinical, you just see the child, no response to steroids is a bad prognosis, and you worsen the prognosis of AML by giving steroids without a marrow. So let's see if we've understood anything since the morning. These are two kids. One comes with upper orbit swelling, one comes with lower orbit swelling. Both have fevers for a month. One has high fevers and one has low grade fevers. One has a wrist joint pain and the other one has foot and ankle pain. One has morning stiffness. Now we will all ask morning stiffness in every kid. One has nocturnal pain. And both CBCs are essentially normal. Normal is same. Hemoglobin is 8, white cells 3200, platelets 175, CRP negative, ESR 80 and ESR 100. I'm not going to Bombay today also, so I have lots of time unless you guys want to spend the evening with me. The president is smart. Bhag gaya kahin to. Yeah. Oh, you're there. Come. It's good to torture neonatologists and intensivists. What's the story? Both are the same, na? CBC भी same है, सब कुछ same है ना? So the kid on that side was referred to me by a very clever pediatrician, Bhavesh Mitia. He said, Vijay, तेरे type का ही है कुछ तो, and I feel this is not cellulitis. Is this cellulitis? दो आँख सूजा हुआ इतना? Is it bacterial cellulitis? Orbital, periorbital? Everyone is nodding this way. Means no. Why? Bilateral, no? Generally, you won't have bilateral orbital cellulitis. But he's gone through the usual stuff. Cellulitis, nephrotic, sab ho gaya. फिर भी आँख सूजा है. And then, fever for a month. I am very happy to have high fevers in my practice. What I fear is low fevers, right? Or undocumented fevers. Wrist pain and ankle pain could be anything. Morning stiffness versus nocturnal is a clue. What's wrong with the CBCs in both? Or it's a normal CBC? एक हफ्ते का हिस्ट्री है तो वायरल, 2 हफ्ते का होगा तो शायद EBV, सम एक्सटेंडेड वायरल, 3 हफ्ता हुआ तो एक बार कोविड एंटीबॉडी बेच के मस्ती करेंगे, 4 हफ्ते के बाद इज अ प्रॉब्लम, राइट? व्हाट्स रॉन्ग विद द CBC? Which is lymphopenia and which is lymphocytosis? So my way of thinking of CBC is, why is the first one on the P80, L15 can be neutrophilia also, no? So the way which I have trained myself is always go with the absolute WBC count. If counts are low, then pick up whatever is low in the differential. If counts are high, pick up whatever is high in the differential. So in that first situation, counts are 3200 and I am looking at lymphopenia, right? Added way of thinking is it's a girl child who's 7-8 years of age. Whereas here it's 3200 with L65. It could be neutropenic, but then something tells me that it could be a lymphocyte which is increasing over time. Remember what did I say? Unless you are an infant or a viral, you are not allowed to have lymphocyte predominance after 1 month. And nocturnal pains, right? So what's the kid on the left and what's the kid on the right? I said one is on the... Sorry? Yes, so what does that signify? Both have some degree of inflammation, but morning stiffness on the left of mine and night in the right. So when you see possible chloroma, so SLE, right? Open the mouth, problem is down, look up. So hard palate ulcers, the kid on the left turns out to be lupus and the kid on the right turns out to be a leukemia. And the same, these are actually the pictures of the same kids. Articular versus periarticular. So even before you do an ANA, you have a ready-made diagnosis in front of you, right? Perfect. This kid again is, I'll quickly run through it. This was a child who came from Solapur or Sangli with a diagnosis of rheumatoid factor positive poly JIA, the right gender, the right type of joints, being managed by an adult rheumatologist, but after 6 months of treatment, still this child was not getting better. Remember, RF positive, the commonest differential for RF positive is a false positive RA. And then this is how this child came to me with. Tell me if he's happy or sick. ते पाय सर कर. Severe bone tenderness and no fancy tests for him, and his white cell started from 10,000 to 15,000. When I saw him, the latest white cell was 65,000 with lymphocytes 90%, with a huge liver and a huge spleen. And again, no prizes for guessing that this child was a leukemia. And this is, a very easy thing to do is do an X-ray of the bone. At 3-4 months at least, you will start seeing these metaphyseal lines of lucency. So remember M for metaphysis, if it's not rickets, M for osteomyelitis, M for malignancy. So the biggest mistake you will do is not diagnose a malignancy, and the more biggest mistake is starting steroids without a diagnosis. So what are the clues? Acute, subacute arthritis, low-grade fevers, sick child, periarticular swelling, high ESRs, and remember opposite directions. The other extreme is very easy, just 30 seconds on this. You may have this daily OPD kid who will walk in with severe leg pains in the night, ESR 20, growing pains. Comes back again, give calcium. Comes back again with abdominal pain, give no worm or bandy or whatever. Comes to you the 4th time, please refer to me. One trade secret, I won't, there was a meeting on Wednesday, on growing pains. They talked about everything except my trade secret, which is there in the slide, but we will not touch about it for now, right? The next situation where you can have a child with acute arthritis is quick. Bilateral knee arthritis. First question you will ask is morning stiffness or evening stiffness. This is morning stiffness. 12-year-old girl should strike a bell. HB is 10. We won't see the HB. White cells, lymphopenia or neutrophilia. We just discussed in the previous, counts come hai to lymphopenia. Platelets less than 2 lakhs in rheumatology world is low. Don't wait for 30,000. The minute it becomes, I am happy with 201, but I am not happy with 199. Like Bata Chappal. Anything more than 2 lakhs is reassuring to me, right? This is low. CRP negative and ESR high. Remember this mantra always. And you will get this combination only if you send it. And it is very, very suggestive or suspicious of, right? You may have lupus presenting in an acute scenario with joints, etc., right? Don't wait for the full set of criteria to be fulfilled. So many collagen disorders can come to you in the first week with acute arthritis. Most of us have seen KDs. How many of you have not seen a Kawasaki disease in this room? How many of you have seen Kawasaki disease in this room? Everyone has seen KDs. Perfect. Henoch-Schönlein purpurus? All of you have seen, right? Dermatomyositis. How many of you have not seen? I'm sure there will be some hands which are getting up. So I'll show you a few of them. So the last situation where you can have acute arthritis is this. The PGs will probably have this in the exams. A 2-year-old male who comes with recurrent right knee joint swelling. And my teacher used to say, कुछ समझ में नहीं आता है, though you just stick a needle and aspirate. The only reason you don't stick a needle into a joint is if you don't have hands or if you don't have needles, which means you can aspirate or stick a needle in every joint. And you aspirate and then you draw out blood. और फिर हम लोग अरे फैमिली हिस्ट्री पूछा ही नहीं, पूछा तो बोलेगा मामा को है ऐसा ही प्रॉब्लम. व्हाट्स द डायग्नोसिस? Sorry? Hemophilia, correct? So when you aspirate blood or hemarthrosis, history is very typical on the history. Diagnosis is very typical. Occasionally you may have this child who's on the right who comes with an oligo going on and on. Every time you aspirate, you keep getting hemarthrosis. And then the diagnosis, if on imaging, you may pick up a synovial hemangioma, etc. Rare, but then possible. So if ever you aspirate blood out of the joint, you will keep your antenna up for a localized problem. So coagulopathies. So what's the take-home message from this presentation? Acute arthritis, whenever they come to you, the first step is arthralgia versus arthritis. Second is you probably would make up that sentence that I have told you. More of pain, less of swelling is always the rule. Terminal restriction of movements. I'll show you some joint examination maneuvers in the next presentation. And usually the onset of the pain, if it's minutes to hours, it's usually post-infectious or septic. But if it becomes a bit more subacute or chronic, you will start talking in terms of, any of the other things we talked about, the malignancies or collagen disorders. Usually the post-infectious are lower extremities. Spine, it could be sinister. We know that articular, periarticular, now we are very familiar with morning stiffness versus nocturnal stiffness, and then other signs which we will see in the next few slides. So take home message is acute monoarthritis, which involves metaphysis. Rule out myelitis or bone marrow before calling it post-infectious or subjecting the child to naproxen. When you have a single joint with high ESR, you will think of tuberculosis, you will rule out a malignancy, then you will diagnose inflammatory arthritis. And acute polyarthritis is seldom septic, often reactive. You don't diagnose septic in 100 joints, and it's rarely a sinister problem. Once in a while, rheumatology can cause this. And last but not the least, you have all these reasons for an acute arthritis that we discussed. Post-infectious, Reiter's, transient synovitis, post-streptococcal, infectious, osteomyelitis, malignancies, collagen disorders, and last but not the least, coagulopathies. Invariably, you will find your answers in this chapter. Perfect. So the first slide I told you why rheumatologists are happy. This is the reason that they gave for being happy. So we don't earn as much as you people, but we pay less taxes because we earn less and we don't have anything to hide. We care for, amongst all the reasons, I like the point 8, point 7 because we don't treat the reports, we treat the patient. We do get a lot of hugs from our patient, we don't get a lot of money though. And it self-selects happy people. How many of you here are happy? रोते रोते हाथ उठ रहा है ना. And the last thing is probably Saturdays are the worst and good days for pediatricians, but whereas while all of you were vaccinating and making money, I was driving all the way from Bombay, eating a vada pav from the roadside dhaba, which means that the reason given by them was we are in control of our lives, practice and time, the work-life balance. Narayan Murthy is my best friend, or not my best friend. Gen Z is my best friend because there was this controversy, how many hours you should be working a week. We hardly work. Therefore, most of us know our children's names. So, on that note, I think I'll call it quits for the first. I just shared this nice picture because my actual stint with rheumatology, believe it or not, started in 2016. You can recognize this smart young man here. Who's this? PGs. Can you recognize this person here? You can't. They can't recognize. So you can send them away with me to Bombay. This is 2016 when I came to Solapur last. And I think Dr. Atul and Dr. Vikram were my first antigen presenting cells, as I call them. And it was quite a nice meeting which we had. And on a Sunday, the hall was reasonably full. I look initially a bit startled. I say, "अरे क्यों आ गया यहाँ पे कोई आया नहीं करके?" But the hall was quite full, and this was yesterday actually. So yesterday from here to here, life has come a big circle, and I was thinking, what has Solapur given me? And Solapur gave me my first kid of polyarthritis nodosa. Dr. Vikram patient's name Pranali. Solapur gave me my first systemic onset JI, Dr. Atul Afan Shirshi. I remember the names also. Dr. Pramod Kulkarni gave me my first PFAPA syndrome, Aditya Fattepur. I haven't revised this name, it's there in my head, right? Hyper IgD, again Vikram and Keyur Shirshi, Vihan Rathod. All these seemingly are rare in the कहीं तो होगा, but सोलापुर से ही आया मेरे पास. And KD, vasculitis, lupus, they keep churning out the numbers. So it's just a matter of, keeping your antennae up. But rheumatology does exist around you. You just have to be slightly street smart and start seeing rheumat in every kid that you see. Because I always teach my students, you think of rheumat in all, and because my job is not to rule in a diagnosis, I am ruling out rheumatology. That's easier done than ruling in a lot of infection. You have infection, malignancy, trauma, rheumat का number ही नहीं आएगा. उल्टा सोचो, ये lupus है क्या? ESR, CRP, low counts, ANA positive, do a blot, confirm. नहीं आया नेगेटिव तो रूल इट आउट, बाद में ढूंढते बैठो जो भी है. सो थिंक ऑफ रूमैट, लिटिल बिट ऑफ चेंज इन थिंकिंग and life is sorted. I think we'll get this inauguration thing done and move on to the next part. Tea break? We will never break in the evening then. I think we are going a bit slow or fast or just about okay. Please let me know whenever you guys are done with attention span, we'll wind it up.
Hello. Happy rheumatologist is teaching very happily to all the pediatricians, making our Sundays very happy. So I am very thankful to Dr. Vijay sir. Let us give big applause of claps for Dr. Vijay sir. Once again, I welcome all the pediatricians from Solapur for today's CME. I welcome Dr. Vijay sir, Dr. Atul Kulkarni sir, Vice President, West Zone, and we will have inauguration ceremony. I request Dr. Atul sir to please come up on the stage. Dr. Vijay sir, please come up. Yeah.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि.
Dr. Atul sir to felicitate Dr. Vijay sir. ते बोलो सिप्ला वाले ने बोलो. Akhil, please come up then. I thank academic sponsorer Sipla. I ask Dr. Atul sir to felicitate him. Sir, Vijay sir, please. Thank you. We will have a very short break of 10 minutes and we will continue afterwards for tea break. Question? Sir, question is there.
So, thank you for a very interesting lecture. And one difficulty we have, if that PSRA extends beyond the short duration, then what are the subtle points that we can use? Either by exam,
The course or the
yeah, course or presentation means duration is little bit more, say just 15 days, PSRA.
So it will be roughly 10 to 21 days is what
Yes.
your cutoff.
So what are the subtle points in maybe history or investigation that we can differentiate? Because we have ended up giving secondary prophylaxis. Yes.
So in fact, I distinctly remember one kid
The
where
safer side we have done.
I distinctly remember one kid which was very, very PSRA for me. Severe pain, 10-day history following the tonsillitis, large and small joints, additive, everything looked very, very PSRA to me, which is the straightforward ones, like I said, PSRA 7 to 10 days from tonsillitis, rheumatic fever 21 days onwards following tonsillitis. PSRA additive, rheumatic fever migratory. PSRAs will not respond that well to naproxen or aspirin. Rheumatic fever still behaves the way it is supposed to. Extremely good response to an NSAID. But this kid, and obviously rheumatic fever is the lower extremity, large joints, whereas upper and lower extremities, digits, small joints are generally not a part of rheumatic fever, or so that was what I thought. And then when I send this child, always I do a 2D echo in all of them, especially if it's a proven tonsillitis and ASO is very high. I still run them through a cardiologist and he calls back saying, "Arey, isko to pakka carditis hai." Which I said, "Are you sure?" "No, 100% carditis hai. Give a lot of aspirin to this child." And then we Googled up and found that in a rare article in some corner, it says that you may have overlapping presentations. So, which in a way, what am I going to do is, if I see carditis, in your child, did he have carditis? If he has carditis, then you may not call it PSRA because you will need to give him the prophylaxis that he needs. But if there is no carditis, I may still give a trial of naproxen for 2 to 4 weeks. If it's a polyarticular involvement, if it's only 1 or 2 joints, I might just locally inject steroid and wait and see for the response. Which is, the answer to your question is what's in a name. Most of the times what you are asking me or what I have seen is an exception. It's not common. Most of the times they tend to delineate on their own. And what I'm trying to sell today is the common scenarios. You may have exceptions like this which are a diagnostic dilemma. The issue is you don't want to crucify someone to lifelong penicillin versus you don't want to undertreat also. So I don't know if I have answered your question, but generally 3 weeks is where I will have my differential between PSRA and rheumatic fever. Closer to the 3-week story, definitely a 2D echo. But first 1 week may aa gaya and multiple joints, especially if you see fingers and dactylitis, more chances that you are dealing with a post-streptococcal reactive story. And still for some reason that I have never been able to understand is why do the joints migrate? We have been after this theory since our medical college days. I still don't know why pains migrate in rheumatic fever. I can answer why the pain migrates in a leukemia. Which one of you is going to tell me why bone pains can happen? Why does it happen in the night versus joint pains in arthritis happens in the day? Any clues? None of you want to have tea? It's not there. Okay. but still it will have pain, no? Circulate hoga to bhi. You are true, you are almost there. So everything is connected to circadian rhythm. So remember, all this inflammation happens because of TNF alpha, IL-6, etc. I haven't forgotten your question. I'm just diverting it so that answer नहीं आता तो कुछ और करके घुमा लो लोगों को. Election season, no? So IL-6 is the commonest mediator in systemic arthritis and JIA. That has a 2-time secretion, one in the early mornings and one in the late evenings. And so as a rule, what I preach is morning 8 o'clock, God gives us cortisol. Evening 8 o'clock, God gives only rheumatologists melatonin. Pediatricians, I think, get a pulse dose of methylpred at 8 p.m. in the night. 6 a.m. is when IL-6 is at its peak, and the more IL-6 which gets released in the joint, you start producing more inflammation, pus, etc. in the synovium, and like you rightly said, movement keeps making it better. That's when morning stiffness gets better. The 8 a.m. cortisol, what's the treatment of JIA? What's my commonest medicine I might use? Prednisolone. Morning, God gives us natural prednisolone, which takes care of my pains in the mornings. So one theory why leukemic pains worsen in the night is by 8 p.m. in the night, the steroid levels start falling down. So whatever God's protection against pain, against this malignancy pains, that starts weaning off in the nights. And the proliferation of the blasts cause more realization of the pain in the second half of the day, which sounds logical. There are other theories, but this is probably the easiest way to understand is, and simple story, morning pains, not a problem. Evening pain, ESR 120, do a marrow. Evening pains, ESR 20, refer to a physiotherapist, stretching, massage, etc. Growing pains. I don't know if I answered your question, but I think it's one of those things where what I practice is do a 2D echo for all of them, because शहाणपण आणि दीड शहाणा, you shouldn't be missing a rheumatic fever, but it's been a while since I have seen rheumatic fevers. I don't know if you still are seeing commonly in your practice. I think even the medical students during the exams might be seeing a 20 or a 25-year-old, not a young rheumatic fever. Naproxen, the response to naproxen is brilliant in rheumatic fever. For some reasons, the PSRAs are not that greatly responsive like the other forms of chikungunya, dengue, adeno, arthritis that we see. For some reason, the PSRAs are quite notorious. They don't respond that great. So I have injected quite a few of them to get them out of trouble. So it's the only type of reactive ones which are a bit stubborn to treat. I don't know why. Sorry? Yeah. And don't do ASO in the first 3 weeks. That's again a very common, unless someone you see a bacterial tonsil follicles, someone who's chronically having throat issues, fine. But if you see a fresh bacterial tonsillitis within 1 week and you send an ASO and it's normal, remember that ASO starts rising only after 3 weeks. And then you don't repeat any ASO to see if it's coming down, because that can remain positive for longer periods of time. And I think the magical figure of ASO is 333. In one of the IAP cardiology consensus articles on acute rheumatic fever, they reached a figure of 333. Typically, your ASO reports will have 200, which is the adult cutoff. So if your ASO is 250 in a child, you may choose to ignore. But if it is obviously 500, 600, 700, don't repeat it to see if it's coming down. It's better to treat it. Before giving naproxen, please get a 2D echo done.
Yes, Vijay. Last 2 months we had, as you said, like an epidemic of scarlet fever. It was all over India. most of the children, they have not received probably the full course of 10 days of penicillin or amoxicillin, which is the recommended drug. Some has probably received azithromycin, some received some oral medications by general practice for 2 days, 3 days or 5 days, because few patients settled down immediately, few took a longer time. So have you seen any complications like post-strep, this is reactive, this is one, and rheumatic fever also? Or any been reported all over India? Any reports are there for this?
So thankfully no rheumatic fever. One cardiologist called me from D.Y. Patil Medical College that I am seeing a rheumatic fever, but it's one of the exceptions. So general thing is, I don't think I've seen a rheumatic fever yet. But having said that, while the pediatricians were debating which is the best way to sort out red lips, I have 3-4 slides on what I think you could have made out of that, because the minute the pediatrician sees scarlets or red lips, I start seeing a lot of PSRAs, Kawasaki diseases obviously, Henoch-Schönlein purpuras and polyarthritis nodosa. What's common to all of them and scarlet is ASO titer. The issue was that someone with follicles was ASO negative. Someone who was ASO positive even before starting amoxicillin became afebrile. Someone who was ASO strongly positive never came to you, or when he came to me, he came with peeling of skin. So all possible combinations were happening. And what I am worried about is, wo now scarlet chhut bhi gaya. In fact, in one of our groups, there was a post that child becomes afebrile, to which I had asked a question, do scarlets get better without antibiotics? I thought it was a bacterial infection, to which the answer which came was, some of them do. I am not very sure of, but that was like an eye-opener. Do scarlets get better without antibiotic? So my explanation is, A, it is not scarlet, it is a viral, or it is a mycoplasma where you don't use augmentin and give azithromycin, or maybe some of them do get better. My worry was, I always believe in being aggressive or proactive and treat, because I am worried about post-streptococcal sequel. He may have escaped the first episode, but he may come to you with a glomerulonephritis or a rheumatic fever for that matter. So it's still a grey zone. Thankfully, that crisis has gone away. But it's very easy. If I see follicles, you will still, for me, the differential is only ASO versus EBV. Because as we know, infectious mononucleosis will look exactly similar. Then it's just a matter of money, not an issue. Please send a biofire. Whatever worth it is, In India, we are a bit conservative because we think we are rational. But whatever literature I read during this debates, etc., the whole world, especially the rheumatology world, paradoxically, says that you use the biofires to the maximum to rule out infections, to rule in Kawasaki. Which, that rule, I think, if I start talking in IIP meetings, I won't get another invitation for a lecture. Saglancha biofire kashala bolto. But in relevant situations, if it shows an adenovirus, if not anything, you will have a plausible explanation. Having said that, I think in Solapur you have adenovirus associated with Kawasaki disease. You have all sorts of combinations happening. So, see, sometimes it's better if I try to pretend to be Dr. Amdekar, treat what's happening rather than think about why is it happening. If the child is symptomatic, think what's the pathology, document inflammation, and choose the best possible modality. Rule out a bacterial infection, and then it's easy to start anti-inflammatories. Long answer.
Sir, we will continue. The tea will be served at the place.
That will be better, I think.
Yes, because afterwards we will get late.
Perfect. Perfect. So from acute arthritis, no, I'm fine. have it a bit later. I can't sleep actually, no. You guys can sleep. If I start sleeping, then my job is to make you fall asleep. Okay, so should we wait for Dr. Vikram? Or he's gone somewhere, or he's gone into hiding. Okay, so this is the way I thought I should start my chronic journey with the way I started life. Who's this person? Who's this person? If he hears that he is Amdekar, then someone may not like it. Who is he? Sorry? Doctor, that is Dr. Koop Chandani. And who's this other famous doctor next to him? That's me. Believe it or not, that's me during my DNB days. And this picture was during the first National Conference of Pediatric Rheumatology. So I did rheumatology, then I started ऐसा supporting role type होता है ना, बाजीगर में शाहरुख खान in some corner types. And then I just came out of college. What's common to him and me? Angry young man. You think I'm angry? I was angry then. Patientच नव्हते. Vaccine देऊन काम चालू होतं, rheumatology का घेतली? What's the other similarity between him and me? Perfect. So Vijay. So I said how to sell myself is use his name. And I think one thing I was quite okay at was holding the mic at a very young age. You know, and then Amdekar sir taught me की ज्याला काहीच येत नाही तोच खूप चांगला बोलतो आणि खूप बोलतो. So and then I started befriending. Who's this man? Let's see if you know what we discussed. Who's this man? Loudly. Okay. Solapur happened 2015-16 and that kind of kick-started my journey. And then it was all मैं और मेरी तन्हाई, मैं और मेरी तन्हाई. So I heard, Dr. Lokhande speak for 5.5 minutes on CTEV last week. I have used to 50 such presentations where I used to be मैं और मेरी तन्हाई. Always the halls used to be empty. सर्टिफिकेट लेने के बाद मेरा टॉक आता था या सुबह सुबह 8 बजे मेरा टॉक आता था. That's the way rheumatology used to be. And I thought I was getting busier. Who's this? We'll get a special prize for guessing. Who's this? This is me only, no? Without steroids. But then this is what happens in the rat race. You keep running from pillar to post. Busy, आणि कितीही rat race जिंकलात तरीही you will still remain a rat. Maybe a obese rat, if you may call so. This is for the PGs. Once you start passing, your aim should be physically fit, mentally fit. Developmentally, I can't blame your generation, but you should be fit. But don't waste your life like in worrying about wrong things. And this was when I was not having any patients. I used to come to Pune because to go to Bharati Vidyapit, where there was a lot of academic work and something to keep your brains happy. But this happened on one fateful day, So 6th of November, you guys should wish me a happy birthday a second time. So what's this? This was my car. And this somersaulted 4 times on the expressway. I don't drink and drive. I was wearing a seat belt. It did open on time. But this was my car, which was which brand is this? It's a Creta. Now it's ex-Creta. Okay. And you can see that this was only the door that opened and the rest car is all squashed. And this was the only injury I walked out with. Okay. So this is called was karma or karma. And at that day, before the accident, I was wondering why am I even burning my own fuel? जाके गरीबों का भला करके कुछ फ़ायदा है क्या, etc., etc. And Why should I die because of some idiot crossing me from the wrong side? And once this happened and you realize that every Janma, you should probably trust your karma, and you will, I wouldn't mind being a pediatric rheumatologist in as many births, because this is what happens. This is all dua and karma. All the freebies, the poor Raju Rastogis as I call them, those kids from Bharati Vidyapit, this is all the blessing that, allowed the airbags to open. So you don't need a Mercedes. Even if you have a hard-earned Alto, just pray to God that the airbags open. And that's one more philosophical message, right? As luck would have it, around this accident, I started befriending people. Jupiter Hospital, we had a nice team. DNB happened, the students started coming. There was more motivation for studying and teaching and publishing. And then I started making more and more friends, and I'm not making this story. I think Solapur was the little shot in the arm that pushed you, and these four gentlemen were the ones who gave me my first few patients, and then the rest is history, as I say, so it's been a long relationship till then. So after that boring part of my life, let's go to chronic arthritis. I'm skipping, most of us know what's chronic. And the next few situations are very, very classical. What I'm going to show you is, for all practical purposes, chronic arthritis is JIA, right? So this is a 2-year-old girl who will walk into your clinic limping for 7 to 8 weeks. It could still be limping for 2 to 3 weeks. So what's the first question you will ask for tomorrow? Sandhe dukhat asel tar sakali ki sandhyakali, right? So morning stiffness, and she gets playful by mid-afternoon. And then the problem with children is they don't know which joint is affected. And then occasionally they may notice one leg is thin, etc. So with this history, the take-home message is it will be a happily limping child. How to proceed? So remember, the best way to examine an ankle joint is from behind. Can you see this swelling? Yes or no? So always see the joint from behind when it comes to the ankle, and the knee is obviously easily visible. And then when you see this child, what do I mean by a happily limping child? You can see this is a very subtle, which side is affected, right or left? Perfect. There's a little bit of a drag that you will see. Is the child happy or sick? As compared to the previous presentation, this is a very happy child with a very subtle swelling. You don't need 6 weeks to diagnose this. This is a young child with an oligoarticular or less than 4 joints. This is straightforward JIA, right? Now, what if in some situations this child, which starts with one joint, starts adding up more and more joints over 6 months? And then the only test you will send in this young age is a ANA. By which method? ELISA or immunofluorescence. So immunofluorescence, right? You will not waste the patient's money on an HLA-B27 in this age group. So the first situation where you have less than 4 joints is oligo persistent JIA. And if it starts adding up, you will call it oligo extended JIA, which means if the patient visits Dr. Lokhande first time, one joint, he does ANA, he calls it oligo JIA. औषध चालू केली, वाढत गेला सूज, he goes to Dr. Srinivas who says, hey, त्यांची diagnosis चुकी आहे, हे polyarthritis आहे. But the important message is it started like oligo, then adds up, versus somebody who's poly all throughout. The first situation is ANA positive. The second situation is generally a RA positive situation. It is important prognostically, right? I'll tell you why. So this kid was actually the worst I have seen. She's a 6-year-old with a fixed neck, bad joints, bad fingers, deformed knees. But what is characteristic is it's very symmetrical. The minute you start seeing symmetrical involvement with high ESRs, it is an inflammatory polyarthritis, right? So the clues for oligoarthritis is age is less, number of joints are less, girls more than boys, And this time there is more of swelling and less of pain. And this child needs only an ANA because inflammatory markers will also be less. So the take-home message is 2-year-old, 2 joints, ESR2, morning stiffness, girls more than boys. You will straight diagnose juvenile oligoarthritis and only send A for ANA by indirect immunofluorescence and then diagnose juvenile oligoarthritis. The more the ANA is positive, the higher are the chances of silent iridocyclitis or uveitis. So that's the importance of ANA, right? So no role of sending any RA factor or a HLA-B27 in the young age group. Now, instead of a 4-year-old, you have a 14-year-old who has pain and swelling of large and small joints, upper and lower extremities. We know that we will have morning stiffness and no systemic symptoms. And obviously, an excellent response to NSAIDs. This is a tailor-made situation for polyarticular rheumatoid arthritis, which resembles the adult RA. And this situation, will you send an ANA or an RA or both? Don't go by what I have written, I can be wrong also. Only RA, how many people? Okay. So RNA is a good option. ANA or RA? Both should be sent. Perfect. ANA for the lupus part of it, because lupus can present with arthritis. Excellent. Will you send a B27 in this? No. So just remember B for boy. Unless you have a rare exception, your girls should not have a B27. It's usually a boy disease. And this is how the hands will look like. This is very classical, symmetrical, adult RA type picture, right? So the clue is usually RA positive, according to the books, starts from age 8. More joints, symmetrical, and usually the markers will be high, right? No role of B27. You will get an eyes checked nonetheless. So the third situation is, this is probably the next few slides are very important, is joints with or musculoskeletal symptoms with fever. If I have a child who's having fever for 3 weeks, 4 weeks, how to find out if it's infection, inflammation, malignancy, trauma? So this, what used to be called as an aspirin test, these days we do, or I do a naproxen test. So once you have this 3-4 weeks of PUO, you've exhausted all your infections, usually, malaria, dengue, typhoid. Then you give them a 3-day course of naproxen. If both of them respond, fever goes and the pains go, you are probably dealing with an inflammatory story like a systemic arthritis or SOJIA as it was called. If the fever goes away but the pains remain, you remember my last presentation. Fever gaya lekin pain nahi ja raha. Remember, the bone pains will not respond to naproxen. So you may think of ruling out a malignancy. And if both of them do not respond to naproxen also, then you will intensify the search for some occult infection collections. So the 3rd, 4th week is the time for PET CT scan or a full body CT, etc., etc. The whole world is moving towards escalating a PET CT in the diagnostic algorithm for POs. So 3-4 weeks, if it's not going away, even after naproxen, you might find a retroperitoneal collection or a liver abscess or an ovarian tumor or something like that, especially in girls. So do not shy away from doing a CT. The PGs in your exams, it's still chest X-ray and USG abdomen. If you say PET CT, you will fail because your examiner may not have heard of PET CT. He might be an old timer. So exam में pass होने के लिए chest X-ray, USG abdomen. But in the practice, the practicing pediatrician will probably set the kid up for a higher form of imaging, right? And the easy thing in rheumatology, these are 2 terms I have coined, fever with high counts. I call it pyrocytosis. No textbook will have these words. and fever with low count is pyropenias, right? And these are only a few conditions which I have to rule it out, and in the process of ruling it out, I may rule in a few diagnoses, right? High counts and fever is systemic arthritis, polyarthritis nodosa, Kawasaki disease or vasculitis, and the cytopenics are very few, SLE, Sjogren being the prime. Occasionally you will see Kikuchi, which is, we won't talk about it now. And obviously more important is ruling out a malignancy with low counts like we saw in the previous presentation. And it's always a good thing to keep revising. Acute phase proteins. What are the acute phase proteins? Sorry, loudly, loudly, loudly. If you're getting late, it's because of the PGs. Perfect. So there are proteins which go up more than 25% with inflammation. And there are different groups, but I want you to remember C3 fibrinogen is one protein which goes up in inflammation, and CRP which goes up in inflammation. These are positive acute phase markers. The negative acute phase marker which goes down in inflammation is albumin. So we all know albumin will go down in chronic diseases, but in an acute inflammatory setting like Kawasaki disease, you will have a low albumin. So short history low albumin is almost a pointer to a inflammatory process. Why does this slide come here? What's the price of this? I hope you can't see. This price was 1 year back. You know, like the share index, the price of, what are these? Kadi patta, no? What's the kadi patta ka price yesterday? Is 16 rupees for 100 grams in Mumbai. But I'm sure none of us buy kadi patta, no? We are getting used to it, getting free. What am I trying to sell here? This is my favorite blood test. This is the second hint. It was discovered by this poor human being who I am trying to salvage now after 150 years of him discovering this. Edmund Biernacki reaction was the first name of the blood test which I am referring to. And after 150 years of his discovery, they started felicitating him as a mark of respect. 150 साल उसको किसी ने भाव नहीं दिया, 10 साल में मुझे कौन भाव देगा, correct? This is the hint. It's deemed as non-specific right from the first day of medical college, but not doing it is not done. It is depending on the fibrinogen and the globulins in the blood. Messrs. Ganong and Guyton will also be unhappy if you don't guess the test. It is reflective of the inflammatory milieu. It can be low, falsely high, and even before sending it, we knew that it is, along with mycoplasma IgM, this is another test जो भेजता ही नहीं है, भेजा तो भी हम लोग उसको सस्ते में निकालते हैं. Any clues? This is something that I want to carry before I leave Solapur. How many of you have heard of Nasle Bandhu? Nasle Bandhu शेंगा चटनी डाला तो सोलापुर आता है ना. So anyone who comes to Solapur has to buy this before he goes to Bombay. Paradoxically, their name is Nasle. ते असायला पाहिजे होता ना. Rheumatology मध्ये पण असायला पाहिजे एक टेस्ट. So someone of you have guessed it right. So in Solapur, you buy Nasle Bandhu शेंगा चटनी. In rheumatology, you send an ESR. This is ESR, nothing great about it. And even if it comes non-specific, if you see ESR, the first thing that even Google will teach you is the fallacies of ESR, not the benefits. If I mount a tube and the Maushi pushes the table and the tube tilts by 3 degrees, the ESR gets skewed by 30, believe it or not. And even the pathologist doesn't want to suck blood in the first thing in the morning. So करना है और कैसे interpret करना है. We've seen a few situations when ESR and CRP going in opposite directions, it definitely comes handy, right? So that is ESR. 2 kids in OPD for you with chronic fever and arthritis. 2-year-old boy, 9-year-old girl, fever for 10 days and fever for 3 weeks. And the first kid has 3 spikes per day and the 9-year-old has got only 1 spike per day. Sometimes one spike today, एक दो दिन fever नहीं आया, फिर से fever आया. And you have done all the workup and everything is nil. And you do a CBC, and this is a very typical CBC. 18,000 counts. Is it neutrophilic or lymphocytic or lymphopenic? Excellent. Platelets. Are you happy with this CBC or unhappy? Relatively. Relatively happy, no? Everything is going in one direction, I am happy. No going ulta sulta. How will you solve this mystery? Only one test is permitted. You've done the usual stuff, you know, CT ho gaya, culture ho gaya. Let's assume bone marrow bhi ho gaya. From what we have learned since morning, what will you test? Perfect. Naproxen test. And that will, what else? You know the diagnosis? We are in arthritis. So what's the diagnosis? In evolution? Sorry? What type of JI? Sorry? Oligo में fever नहीं आता है. I told you it's a happily limping child. Sorry. Only one type with arthritis will have fever, and that is systemic JI. So what's the test? Will you send an ANA or an RA in SOJI? Or you send something else? Remember, systemic arthritis is a very, very fiery condition. Lot of inflammation. So F for fire, F for perfect. So ferritin. So either I give a naproxen trial or you give a ferritin, and you will see magic. 3 bar wala fever will suddenly become once a day, and then once a day will become once in 3-4 days. What's that fever called as? Quotidian fever, correct? And that's for quotidian fever. There are only 2 differentials usually. I'm not talking of malaria. It's either TB or it is a systemic JI, right? There are exceptions, but most of the time this situation, if I do a naproxen, the fever may become quotidian, giving you a clue, or the fever may disappear and then it will give you some time and the disease may evolve later. And you will obviously see ferritin, which will be high. How many of you have not seen a systemic JI in the room? All of you have seen it? You can raise your hands. I'm not going to crucify. How many of you have seen or not seen? Not seen. So this is, you can come closer. I don't know if you can appreciate, what am I trying to show is a salmon pink macular rash. You will see a rash with the spike of fever, especially around the hands. Can you see this rash on the face? Sometimes it may look like urticarial rash. Can we switch off this light? इकडचं light बंद करू शकता फक्त वरचा. So there is a kind of a हे false light जे आहे, तिकडचं पण screen वो नहीं जाएगा. So you can appreciate a rash on the face. It can be urticarial at times. And this rash typically comes up with the fever, and when the fever goes away, it kind of mellows down. It's the classical evanescent rash. And sometimes the kids keep scratching. What's this called as? Kobnerization or dermographism. So dermographism, what's the commonest differential for it? Skin, psoriasis, correct. Right? And then these are some more pictures. This was a very young child who started having 5 weeks of fever, rash, hepatosplenomegaly. And this CBC, please remember, high counts, high neutrophilia, high platelets, very high ESR, very high CRP, with or without Kobnerization. This child was acutely scratching but extremely sick, and the ferritin came as 8,000, right? And this is the more textbook picture of an evanescent salmon pink rash. And when you start seeing high grade fevers in a PUO going on for 2-3 weeks, just tell the parents to see for the rash. I know the other thing which we are taught is Indians are black. You won't see any rash. But if you notice, you will definitely see either an urticarial rash and or a macular rash. Occasionally you can see lymphadenopathy or bicipital tenosynovitis. The key message is see the pattern of fever. Someone who gets 2 fever spikes in a day, just don't bombard them with antibiotics. You know, meropenem, vancomycin, piptaz, and then you give mefenamic acid, and then the whole pattern gets adulterated. and against the most uneducated patient will tell you दिवसाला 2 वेळा ताप येतो किंवा एक्झॅक्ट संध्याकाळी ताप येतो 24 तास खेळत असतो जेव्हा ताप येतो 105 otherwise the child is extremely happy but before the fever comes the child will become thoda dull thoda drowsy and the pain will be there and that's the time they may show you the rash and if you send a CBC you will have anemia you will have severe neutrophilic leukocytosis and thrombocytosis with or without arthritis at the onset and sometimes they may be really sick to have polycirrhositis etc. So what's the systemic arthritis workup, right? We have seen the CBC, HB8 and this is pyrocytosis with this kind of a CBC is always suggestive of SGIA. You will send a ferritin as rightly pointed. A normal ferritin is 150. This child will probably have a ferritin of 1500. LDH, SGOT will be high. Fibrinogen being high. ESR is high. So remember if your patient is not affording, ESR is a good indicator of fibrinogen and CRP is a good indication of interleukin 6. So stop doing IL-6 and fibrinogen you may throw in once in a while and triglycerides obviously because the other side of systemic arthritis is what if the same, if I pretend to be virus and say कि 25,000 से एक 0 हटा दिया और 2500 हो गया WBC and ferritin from 1500 goes to 5000, LDH is climbing, enzymes are climbing, ESR is dropping, perfect. I don't need to waste more time. So remember systemic JIS, the reason this, how many of the students know the importance of this coin? What is this coin? Where have I got it from? And what does it show? In this context, systemic arthritis has got two avatars. One is the angry inflammatory avatar, which if you sit on it, you will end up with a macrophage activation syndrome. And the reverse is also true. A child who comes with cytopenia and HLH, get him out of trouble and he will evolve into the full-blown SJIA. So lupus, Epstein-Barr virus, dengue, systemic arthritis, all of them can come with the right side story. Get them out of trouble, child recovers, good for the kid infection. But if he evolves into the left side with the rash and joint, you know that you are heading towards a systemic arthritis, right? This is the commonest situation which the pediatrician encounters. Again, not in rheumatology, but 12:36. I have 8 hours more, no? This patient comes to Dr. Vikram. He comes with fever of 7 days. And he is a busy pediatrician who does not have my magic pen yet. And he does a CBC. HB10, white cells 25,000, platelets 7 lakhs. And he says, विजय ने बोला था कि सब कुछ हाई है तो हाई का टाइम आया नहीं है अब तक, right? And he starts antibiotics and sends cultures. This same kid continues to run fever and he says हाताचा गुणच आला नाही. I'm sorry, I'm using you because you are the first person. उसके बाद we'll take another opinion करके वो उधर से सीधा इधर आया और सोलापुर का प्रेसिडेंट कौन है करके उसने गूगल किया and he comes to Dr. अण्णा साहेब. He says हे माझ्याकडे वेळ नाही आहे, तुझा परत CBC करून येशील. And this time the same boy from 7-day fever goes to 13 days and comes to another pediatrician who is quite sane. He says CBC HB 9 आहे, WBC 25-15 झाला, platelet 190 in the busy pediatric life is normal. Okay, and he says मेरोपेनेम नहीं तो भी पिप्टास तो चालू कर देते हैं, 2-3 दिन के बाद देखेंगे. And the same child in the next 3 days comes to the third situation. HB drops, 15,000 becomes 2,500, platelets become 70,000, and then he lands up in Ashwini. How many of you are happy with the first situation? How many of you are happy with the last situation? And how many of you want to be in the middle situation? Chances are that most of you will encounter this child in the middle situation. So how do I make sense of this? With two things. I am not a BJP supporter, but I call them my double engine in rheumatology. What is my double engine? Magic pen, here's a hint. Loudly, loudly, loudly. Okay, your wish is my command. So you throw in a CRP and an ESR in this situation. Are we wiser with that? Surely. So the first situation I told you, if I am driving at 200, as long as the Bajuwala is driving at 300, I don't have a problem. It is at least giving me time to diagnose. And I am certain that these kids have been there in Solapur because I have diagnosed in collaboration with the same pediatricians, and the recognition of pattern is important. By day 7, day 9, day 10, most bacterial infections are out. And this is a child with Dr. Vikram who will be happy in between two spikes. So once a day fever, by the time it reaches the second pediatrician, that once a day, twice a day will become 3-4 times a day. So that intermittent will become remittent and continuous. And then on the face of it, the middle CBC looks normal. But if I see the previous CBC and now, 25,000 has dropped to 15,000. Child should have gotten better. Platelets have dropped from 7 lakhs to 190. They have dropped. What's happening to the markers? CRP 200 and 150 for me is the same. ESR has dropped. Patient should be happy. But patient is not happy. Fever बढ़ रहा है. That's a clue that the 80 ESR will never become 15 overnight. If it becomes 15 overnight, you are in big trouble. But God is kind on us. He gives some time for things to evolve while you wait for things to resolve. So the last situation is very scary. What's the last situation? Perfect. While many of you will see meconium aspirations, remember macrophage activation syndrome. It does exist. But the first thing, I call it as a occult macrophage activation, which if I have 100 systemic JIAs and I do a bone marrow on all of them in that inflammatory avatar, काना कोपऱ्यामध्ये HLH होत असते without manifesting. If you sit on it by doing nothing, then you end up with what is called as subclinical macrophage activation. I am not selling the message that do a bone marrow in all of them, because HLH, remember H for hemat and H for HLH. Commonest cause of HLH is leukemia. Leukemia starts from the bone marrow. So invariably you may hit gold every time you do a marrow. But macrophage activation starts wherever there are macrophages in the body. Glial cells, mesangial cells, Kupffer cells. So if you do a liver biopsy, you are more likely to get mass than a bone marrow, correct? So the third situation is where you will actually end up with trouble, right? What did it need? A little bit of time and a CRP-ESR correlation with the CBC. Get into the habit of doing all of them at the same time. You will at least know whether I have a breathing space, or I need to be urgent, or I need to be emergent. That it's easy, right? Why did I have that slide? This is the pediatrician's 10 p.m. headache, as I call it. In the place where I practice, headache is both for us, because the pediatrician is tired and Vijay goes to sleep at 9. तो 10 बजे फ़ोन करके भी मुझे उठाएगा, मैं नहीं उठाएगा फ़ोन. But this is the phone calls I get at 9, 10, 11. 5-year-old girl, 7 days fever. The SIB also has dengue. Biphasic fever, NS1 positive. Increasing fever after day 6, day 7. SGPT 90, cultures are sterile. The second situation is 9-year-old girl, step ladder fever, Vidal. There are people who do Vidal, 1 in 160. Antibiotic chalu hai, but no response. And the third is Solapur special. 12-year-old boy, fever, palms rash, soles rash, day 7 of fever, toxicity increases. डॉक्सी दिया फिर भी फीवर नहीं जा रहा है. What is common to all of them, and what will you do till I pick up the phone the next day? In all the three, there is something common, no? First one is obviously a dengue. Second is a proven, probably an enteric. And third is a rickettsia. So what's happening to all of them? Why are they not responding? Perfect. So what's common to all of them? It's probably you're looking at an HLH-like situation, and these are other causes which could probably, mimic. So mycoplasma, TB, Epstein-Barr. So you will do what will you do? So don't restrict yourself to ferritin alone, right? So either I wait and watch in the dengue, आज नहीं तो कल ठीक हो जाएगा. In the enteric fever, you may add an azithromycin, and then rickettsia, you may do a Valfelix and add a doxycycline, and send the full HLH workup. If I was the treating doctor, do not restrict yourself only to ferritin alone. Remember, HLH is a dynamic process. Send the pura HLH workup. Do not cut costs, because it is a life and death situation. So ferritin, fibrinogen, LDH, triglycerides, along with CBC, CRP, ESR is absolutely mandatory. And then most likely, either the dengue will get better on its own, the enteric will respond to azithromycin, the rickettsia will respond to doxycycline, and then after 48 hours fever goes away. You, out of academic entries, you may do the same thing and find that everything is falling back to normal. Life is happy. Occasionally, if you do a test after 48 hours and the fever persists, and the ferritin from 2000 goes to 14,000, ESR drops to 35, CRP climbs up, aren't we wiser by doing just a basic CBC, CRP, ESR? You know that the child is going more towards an HLH, and failing the appropriate treatment for the known infection, you may need steroids. Again, it's just because I am a rheumatologist, I don't bombard steroids. It's just a matter of किती लोक येत आहेत, व्हेज किती, नॉनव्हेज किती, कांदे चिरून ठेवा, etc. and then start cooking. Make your playing field ready. Do the baseline HLH workup. Trust the patient's karmas. Hopefully, many of the post-infectious ones will recover. If they don't recover, either they are hitting rheumatology or they may need occasionally the steroids. Message is simple. If I have a known infection behaving a bit abnormally, think that it's an infection-induced complication. And just don't stop at ferritin because iska ferritin 500 आया, तो क्या? Right? So ferritin 500 is borderline. Ferritin 5000 and above generally indicates an impending macrophage activation syndrome. Especially in dengue, if you have a ferritin of more than 10,000, you are almost sure it is HLH. Right? Whether to treat or not, the problem that happens very often, it will start in the next month or so. Once it starts raining, every kid with dengue will have an SGPT of 100, 150. I am very scared of this 100, 150 SGPT. Do not ignore the SGPT of 150. The ID people are fond of using dengue hepatitis as a word. The best of brains, because I see the 150 SGPT come to me with 1500 SGPT in 7 days, who comes with fulminant liver failure. Unfortunately or fortunately, the pediatrician does not see that many deaths in day-to-day practice. But when they come to me with a PT-INR which is deranged, a prothrombin time of 100 also I have seen, 100 and above. I said I can't do anything, get a liver from somewhere and transplant, So 30, 40, 50 is fine, but the kid who comes to you with an OTPT at least 1.5 times deranged, at least monitor the serial SGPTs. That's the last thing which my magic pen will help you. CBC, ESR, CRP, SGPT, creatinine, and maybe a SUSU. Finish all of them. End of the day, the liver and kidney are your toilet and bathroom. if I look at it, the disease and the drugs go out through the liver and kidney. And the worst of HLH will make it if your liver and kidney holds up. If you read macrophage activation syndrome literature or HLH literature, maximum mortality is seen in someone whose liver and kidneys do not revert back. A high creat and a high SGPT-OT, deranged LFT is often a poor prognostic marker. And by that I mean, if I have a dengue with a ferritin of 8000 and a OTPT of around say 500, if the child is plus minus, I might give him steroids, right? Doesn't mean you have to give steroids to all of them. Idea is work them up, keep a close watch and be flexible. Don't be dogmatic ki he dengue's ahe, he HLH nahi, because, and dengue is one condition where you may have a normal CRP and a very high and a low ESR. I don't know the reason why, but what literature I have read is dengue HLH with a normal CRP has a better chances of survival than someone with a high CRP. So don't be very rigid about your rules. Saving the kid's life needs a bit of proactive approach, right? Again, no political affiliations. You have to do these two things in most of the situations. I'm sure quite a few of them have seen this slide of mine. ESR high, CRP high. Only 4 situations are possible, right? Infection or infection associated inflammation. If you have a very high CRP and a low ESR and a sick child, you are dealing with macrophage activation syndrome. If you have a ESR that's high and CRP normal, what are we looking at? Negative CRP, high ESR, quick SLE, perfect. And then both are low and the child is getting better, obviously means we are out of trouble. I have tried my level best to sell this message, it started from Abki Baar 2014 में क्या था? Abki Baar, I am not a BJP guy nor a Congress guy. What was the famous slogan? Abki Baar मोदी सरकार. कोविड में मैंने उसको बोला अबकी बार CRP और PCR, उसके बाद अबकी बार CRP और ESR. So whether you become 400 par or not, please get into the habit of doing an ESR. And the way to understand it is, beware a 3-digit ESR in our country. A 3-digit ESR is malignancy, tuberculosis, and then you will have rheumatology. Beware a normal ESR in a very sick child. Diagnosis, macrophage activation, and then at least start doing an ESR. How to interpret? देखो, कड़ी पत्ता खरीदेगा तो उसका भाव समझेगा और टेस्ट भी आएगा, right? And this image, please remember, going in opposite directions is always a risky business. The next type of joint is very easy. From a 4-year-old girl to a 10-year-old boy, lower extremities, with or without hips, sacro. So what's lower extremities? Below the umbilicus. So you have hips, sacroiliacs, knees, ankle, feet, and generally it's a B for boy. Will you send an ANA and an RA factor in this? No. What will you send? You will only send an HLA B27 by PCR method, no flow cytometry. So how do I remember this? This is a knee, and you know now that ankles are best examined from behind. You will have, this is called as what? Enthesis, right? Where your tendons get inserted. Don't waste the patient's money on an X-ray, which will be bang normal, but you do an MRI, you will see all these white colored dirty things are nothing but synovitis. So what's the pattern here? B for boy. Below the belt doesn't sound good. We'll use the word below the umbilicus, and B for B27. And usually it's a B for Bhaiya. In Bombay, if I have a taxiwala from UP ka bacha who walks in, remember SGPGI, Lucknow has the biggest cohort of ankylosing spondylitis patients. So for some reason the UP, Bihar, B for Bimaru is one more thing I keep teaching. And then you can throw in a B for Bachchan also, because Amitabh Bachchan is probably the prototype HLA-B27. I have not leaked out this secret, but his famous joint or dance steps tells you that he has a stiff back, right? So B for boy, B for Bengal, Bihar, Bimaru, UP, B for below the umbilicus usually, and B for boy. You will send an HLA-B27. You will not waste the money on ANA and a RA factor. Easy. This is, most of you know what P-GALS is. So when you do a P-GALS on an 8-year-old, I'm asking him to walk on his heels. You can see that he is in trouble, right? He can't. So if I am having trouble walking on the heels, I have an ankle in trouble. And if I can't walk on my toes, I have my forefoot, midfoot in trouble. But the pattern is very clear. 7-8-year-old boy with an ankle, foot, etc. You are entering the B27 territory, right? And this is the way you examine the hip joint. So the knee getting bent. How do I examine the knee joint is heel touches the bottom or the buttocks. Translated in Marathi, it is tacha to bocha. When your tacha will touch the bocha, your knee is absolutely free. Oops, battery is low. Switch on नहीं किया है? ये मेरा हाँ, now it's charged. Thanks. So heel touches the buttocks, knee is free, right? And how do I check the hip? Take the same knee to the abdomen, that's flexion at the hips, and what I'm going to show is internal rotation at the hip. See what happens terminally, which is external rotation at the hips, at the knee. You see that he's wincing. Did you notice that? Terminally, when I move the knee out, he has a lot of pain because that terminally I am stretching the inflamed synovium. See the other side also. When I push it out, terminally, he will have difficulties. This is the very easy bedside method to examine the knee and the hip, right? Ankle is obviously, it gives away clinically, right? And when you do an MRI of this child, you will see definite evidence of marrow edema or sacroiliitis and the ankle joint, tibio-talar joint effusion. Everything that's white around the joint is the inflamed synovium. So you recognize the pattern, you examine the joint, you have an indication or an high index of suspicion for a B27 and do an imaging, right? That's easy. This is one more kid, So we'll move thoda further. This is same child and we move further. So if you read what are the entheses, these are the entheses in the body. The most common is the knee joint or the patellar enthesis, the 6 o'clock, 10 o'clock, 2 o'clock as we call, and then the tibial tuberosity, right? And then there are other entheses. So this is one more child. Same. What's the age?
2, 3.
Okay. The same age. What's the gender? Now the boy. Which joints are affected, lower or upper? Perfect. So going on for 4 weeks, what will be your first suspicion? ANA, no? RA factor. B27. And then
And when I press this,
I'm trying to demonstrate the entheses. So see what happens when I press the 10 o'clock, 2 o'clock and 6 o'clock. I have not bribed him to act. That's the difference. See what happens.
look there, look there, lift my head, either,
The joint is swollen. But he will have tenderness when there is pressure at 10 o'clock, 2 o'clock and 6 o'clock. That is a thing that will suggest he has enthesis, right? And then you examine him closely because he was having difficulty walking on the toes. What can you see here? Is this normal? The toe is slightly swollen and Yeah. So what's the diagnosis? Excellent. So you may think of, you don't need rocket science or even a dermatologist. No, for the parent it is ghamoya, chappal allergy or whatever. But in the context, you do an MRI of this leg. This is actually what is bad synovitis around the toes. So you have documented it clinically, you have seen it clinically, and you are proving it with an imaging. This is dactylitis at its best. And so, if you ask what are the conditions that are driven by B27, first is enthesitis, second is psoriatic arthritis. And obviously, you do an imaging. Many of these kids, even if there won't be any symptoms, do an MRI pelvis with both the hips. You can see this greater trochanter is an enthesis, right? You can see pubic symphysis sometimes inflamed. That is an enthesis. You can see, so this is nothing but ERA, and you obviously sometimes you'll pick up sacroiliitis. So this is enthesitis-related arthritis. So this was a kid who came to me at 3.5 years from the adult rheumat with a left knee joint. So what does a 3.5 with one joint have? From what we have learned? Loudly. Oligo. What will you send in that child? ANA. So ANA is 1 in 320. And I said this is oligo GI. But because it came from the adult ortho, adults send everything in everyone. Right? So they send everything including a B27. वो भी positive आ गया. And then they come to me, and then I call it oligo. I stop sulfosalazine and I start this child on methotrexate. And then after 8 months, this child adds up one more finger. Now what? What's this finger? What is this called? You have it for breakfast. The vegetarians, non-vegetarians. Sausage. So dactylitis. So acute arthritis, dactylitis is post-infectious. Subacute to chronic is TB. After 6 weeks, if he develops one finger along with one ankle, I call him oligo tha, abhi extend ho raha hai, to oligo extended, right? Treatment doesn't change though, and after 6 years, this child breaks into psoriatic arthritis. So that's the last classification of GIA, which is called as undifferentiated. So you have an oligo persistent, oligo extended, RF positive, SJIA, enthesitis. And the last one is a bit of an overlap. Thoda oligo hai, thoda extended hai, but picture abhi baki hai types. And the picture release hota hai, it doesn't necessarily change what you do, but then you take it to its logical ending. So it was a psoriatic arthritis. The clue was what? This finger dactylitis. Bench lag gaya karke aayega OPD mein. Kab bench laga? 3 mahine pehle. Kab सूजा abhi. And then it's always a good idea to check if any family members have psoriasis in the family, or check the nails for any nail changes. Someone will have pitting, कोणीतरी eczema है, silencer ने जड़ाला, all possible reasons. But then if you see, it will look like a psoriasis to your eyes. See a finger, you will diagnose psoriatic arthritis. Right? So take home message from this is, when you start seeing dactylitis, one here, typically just undress the child. This was one more kid, ऐसा एक उंगली सूज गया तो ऑर्थो के पास गया, ऑर्थो ने इसका बायोप्सी करने का बोला तो पेशेंट भाग के आ गया. Then when I saw this child had a knee also. So, one finger, one knee. Guess the age of the child. It is a young child. So, oligoarticular wala age with a dactylitis. And then you open the full body and see the kuch to hai bembi ke baju mein. Occasionally you can have psoriasis at wrong places or the right places which we don't know. So under the scalp, hairline, periumbilical, etc. are hidden sites where you may pick up psoriatic arthritis. So the last part of this presentation is mimics, as I call it. Let's be quick on this. So 10 minutes of this and we are done. 3-year-old female and 3-year-old male. Both have come after 4 weeks. So 4 weeks is almost chronic. And when you see a joint, what will you ask for today? Morning stiffness, and tomorrow also. CBCs bang normal. When you see slightly high platelets, with a normal hemoglobin, you know there is inflammation. ESR 30, ESR 80. And now we know that 3-year-old is the right age for sending A for ANA. By which method? Immunofluorescence. Perfect. ANA 1 in 320 and ANA 1 in 100. Diagnosis in both of them is juvenile oligoarthritis. True, false, can't say. Refer to Vijay. At least say refer to Vijay, no? It'll make me happy at least. Which is JIA and which is not? Are both of them JIA? How many of you want an MRI? How many of you want to differ? How many of you want to refer to ortho? Raise your hands. Thank you. मेरे पास मत भेजो लेकिन ऑर्थो के पास भी मत भेजो. What's the problem? It is inflammatory arthritis. Agreed or not agreed? Agreed, no? What's the red herring? ESR? Your left or my left? Who supports left? How many of you think that the kid on the left of your screen is oligo-GI? सब कुछ same है ना? What is the red herring? ESR, no? One is ESR 30 and the one is ESR 80. How many of you think that the kid on the right is GIA? है कि नहीं? Correct? So what's the right? Can be tuberculosis, and tuberculosis can be the right answer also. Correct? The clue is simple. Message I want to tell you is, when you have a single joint with a very high ESR, do not be in a rush to diagnose JIA. Please do a MUN2. I know that pediatricians don't believe in MUN2 anymore. They don't believe in quantiferon gold also anymore. They don't believe in the rheumatologists also. But then the rheumatologist has to give steroids. तो कुछ तो करना पड़ेगा ना. तो please do a MUN2 for at least ruling TB out. This kid had a very strong MUN2 and the clinical setting fitted like a tuberculosis. So when you have a single joint with a high ESR, remember ANAs can be falsely positive in 25% normal people, right? And the positive ANA titer is 1 in 100. So 1 in 80, 1 in 60 is very common, right? This child obviously has a very high ANA titer, low ESR. And what's our rule? Age is less, number of joints are less, acute phase markers are less, it is JIA. When age is less, it is inflammatory, but ESR is very high. Please rule out a TB. So same kid, if it had come at 1 week history, septic arthritis. 2-3 week history, tuberculosis or malignancy. If it is a 4-6 weeks, then rule out TB. Occasionally you may have a juvenile oligo with a high ESR, but that you have to rule out the leukemias. That's what I mean by think of TB, rule out a malignancy, then you diagnose JIA, right? So a single joint with a high ESR, please do a MUN2 and or a biopsy following an MRI. Easy. This is just to sensitize you to a new condition, or it's an old condition which we started recognizing. The ortho rings up. एक patient भेजना है तेरे पास. I am sending you a child with osteomyelitis. And I don't think it is bacterial. Very rarely the ortho says it is never bacterial, but I have a smart pediatric ortho who says तेरे type का है और भेजता है. मेरा, why do you think it's not bacterial? Because he says 3 बार हो चुका है और 2 बार उसका operation हो चुका है. And then they are different sites and all the time the cultures are sterile. तू एक बार देख लेना, right? And then the answers to these questions give you the diagnosis. He says, I don't think it is bacterial. So my way of interpreting it is, if it's not infection, it is inflammatory. It's recurred 3 times. And how many osteomyelitis can get again and again and again and again? Very unusual, right? Even if it is PID, you will probably grow an organism at some point of time. So this is non-bacterial. 3 times and different sites. So obviously it's become chronic now and it's getting recurrent. And then different sites is in English multifocal. And then it's always sterile but inflamed. So it is non-infectious osteomyelitis. So there is a condition called chronic recurrent multifocal osteomyelitis. How many of you have heard of this? I think some people would have heard, but a non-bacterial osteomyelitis is an inflammatory osteomyelitis. So if you know, if you have seen a child with an osteomyelitis 2-3 times, think of this condition. And for people interested, please read CNO or chronic non-bacterial osteomyelitis. If not today, whenever you encounter a child with recurrent stories. This was just one example of a 15-month-old child who came to me at age 15. At age 4 months, this child had a right elbow pain and swelling. And then he came to me with this CBC, HB5, white cells 11,000, platelets 4 lakh, and CRP was 10, ESR not done. Ortho reference X-ray normal, MRI was, लूज कनेक्शन है क्या? So this child actually came to me at age 15 with 3 months, with 3 episodes of osteomyelitis. I am fine, thanks. If I start drinking water, I think it's time to wind up. I need to sell a few messages before we'll stop. It is important because the only case report from our country was over 5 years and some 11 odd kids of this condition. So this child came to me with 3 episodes of osteomyelitis. पहला बार एल्बो ऑपरेट किया 3 महीने पे, कंसैंग्यूनियस मैरिज, उसका रिपोर्ट स्टेराइल आया, तब तक दूसरे जॉइंट में सूजन आ गया, वापस ऑर्थो बोला ऑपरेशन करने का, तो पेशेंट भाग गया. एंड ही वेंट टू अ सेन पीडियाट्रिशियन हू सेड काय करू नका, फक्त आयबुप्रोफेन द्या. And this child would miraculously respond to ibuprofen. And then he lands up with me at age 15 months. And tab tak 4 episodes, and all of them he goes to the same pediatrician. The 4th time they only gave ibuprofen because Sarani Sangitla hai. And when you see this child, and this is the serial CBCs, can you pick up anything abnormal in this CBC? And when you examine this child, there is some collection of red colored erythematous papular lesions all over the body. This was the best I could click. What's wrong with the CBC? RBCs are low, right? As much as I keep saying ignore the HB in Indians, this was one situation, especially in a young child. What else is wrong? Can you have a 5-month-old with iron deficiency? Unlikely, no? So when your RBCs are continuously low and HBs are low or lowish, and then, very interestingly, acute phase markers are not very high. So a bacterial osteomyelitis, at least the CRP or the ESR or the white cells should be very high. And it can't recur back. So when you see 3-4 proven episodes of osteomyelitis with a normal acute phase marker, and then you start thinking reverse, ये skin में क्या हो रहा है उसका, hemoglobin का कमियां है, and consanguinity is just the cherry on top, right? And then you realize that ibuprofen was helping, but 4 episodes of osteomyelitis, I could not extend the elbow fully. There was almost a mild contracture, and then serially, because of continuous, you could see this sclerosis, periosteal elevation, or hyperostosis. So when you start seeing reports which read sclerosis, hyperostosis, periosteitis, you will start thinking in terms of an inflammatory osteomyelitis. See this is a very chronic, bottle-like changes, and then most PID workup was done by that time, and you start adding up the list, so make the sentence again. There is consanguinity, there is definite recurrences, there is some dermatosis which we are wondering, and very early infantile onset of anemia with normal acute phase markers. And then you don't need chat GPT. Common sense is find out dermatologist se zyada hematology, we know more hemat. So early onset anemia, the cause is probably in the bone marrow. Low RBC means the bone marrow is not producing RBCs. And then we said, let's at least do a bone marrow, and it came back as dyserythropoietic anemia, CDA. Once in a while, you will see such findings which fitted rightly or nicely. Young age mein, there is no erythropoiesis, there is something defective in that. And I said, let's get a skin story also around the same time, do the skin biopsy also. It said it is consistent with sweet syndrome or neutrophilic dermatosis, which is a fancy diagnosis, but there are 100 differentials. But in the context, if you have neutrophilic dermatosis and CDA and osteomyelitis, once you don't have enough of vaccines, etc., to worry about, which I don't, and then you start connecting, you straight away hit this triad called as Majid syndrome. So I'm not here to, sell something spectacular or super intelligent. Majid syndrome is a very known common condition due to a LPIN mutation, lipid mutation, which can cause recurrent fevers, early onset, chronic recurrent multifocal osteomyelitis, and you will see this trigger, especially I think in Muslims in our country because of high consanguinity. If you start seeing recurrent OMs with anemia, with dermatosis, think that Majid is one form of non-bacterial osteomyelitis. I don't mind if you say enough of rheumatology, we want to go home, but this is, sorry, cafes is a good thought, sir, but cafes would probably get better with age than mandible is more common, but it won't keep recurring for so long. They will, and it doesn't leave a sequel usually. And this, it doesn't explain the anemia part of it and the skin, etc. This kid I want all of you to see because, as I said, this could be the last case of the day. You learnt enough. This mother is very sharp, intelligent teacher, and I said, "Kya hua?" And she said, "My daughter is a dancer and a big fan of who?" And she is doing this moon dance for the last 1 year. She is walking like this. And I almost thought this is an adolescent brat who is just fooling around because none of the known disease you can actually walk like this. And then I thought शायद घुटने में कुछ problem है उसका. Knee looks a bit strange. And frankly I did not have an answer. I said, time please. For sometimes at my age you can pretend to be an Amdekar sir. काही येत नाही तर बोला समोर की नाही येत मला सध्या तरी, पण कुठे शोधायचंय ते माहीत आहे मला. I said, let's give me some time, but let me see you आराम से. And then I saw her very closely. And this is going on for a year on and off, and mom is giving combiflam dila bara zala, meftal dili bara zala, etc. And then I see her closely, and this is how she looks. Obviously, you now know how to see an ankle. There is a bit of an ankle swelling. Her face looks like this. She is a 13-year-old from UP. What was the UP connection I have told you just now? What's famous from UP? HLA B27. And Bombay pediatricians now know that rule. They have done a B27 also for me. I thought it looks B27 in a girl because lower extremity, adolescent, always boys होना नहीं चाहिए, girls को भी हो सकता है. But वो भी negative है. What's there on the face? Can you see something on the face? So what do you think of adolescent girl? ANA भी negative है उसका. RA factor किसी ने भेज दिया जो नहीं भेजना चाहिए था, वो भी negative है. ESR is 35, not 135. So again that marker is not very high. And you can see an ankle pain, but she also has shin pain. 1 year you can't have a leukemia with shin pain. And then some pediatrician had obliged by doing an MRI also. So SI joint was showing evidence of sacroiliitis. So you can see this marrow edema, and then this lower end of the ankle also shows synovitis, marrow edema, etc. I sent her home. I said, file सोडून जा, आम्ही थोडा विचार करून get back करतो. So the mom went home and said, sir, I will send you more pictures of her face, because 2 months back her face was like this. Yes, which should not be affected, correct? But then what is this? As much as I want you to think like a rheumatologist, it's always good to be a pediatrician first. What's this? Such in an adolescent girl. Perfect. What acne is this? Is it normal acne? What's a fancy word we learned? Conglobata. Bata. Okay. So this was hint number 1. And then it suddenly, once you start doing rheumatology, you'll say, oh, acne bhi hai, synovitis bhi hai. So uska mein, I actually had a shin pain also. I said, just get an X-ray of the leg done. And this X-ray, if you notice, this is showing some periosteal elevation here. And there is a small area of lysis in the fibula. Okay. We are in CRMO session, right? So think that you have evidence of some sclerosis, periosteatis, acne conglobata. And I start secreting melatonin at 6 p.m. In the shower, many times I get the diagnosis. If कुछ समझ में नहीं आता तो just put what you have seen. S for synovitis, A for acne, P for pustular lesions, H for hyperostosis, O for osteitis. So just add all of them, and I think rheumatology is not about clever people, it's about clarity of thinking. You just add everything, you reach a condition called Sappho syndrome. So again, like Majid, Sappho is not a hi-fi story, but it is one form of chronic non-bacterial osteomyelitis. The clue was simple, it's just a clinical thing, and now you guys know what Sappho is, what Majid is. I'm sure Solapur, I don't like Solapur because I still have 2 or 3 kids from Solapur who are some rare genetic mutations of varied significance, but definitely autoinflammatory or some innate genetic problems without a diagnosis. This is one of them. And then what happens when you just diagnose this and give them the right therapy? This girl from moonwalk starts to catwalk. This is complete normalcy at 6 months, and then she comes back with everything is completely normal. I wish I could remove this girl from the screen, and this is how she looks at the end of 1 year of treatment. Now it's been 2 years and I stopped the drugs for this kid, right? So the message is simple. When you have evidence of osteomyelitis, osteitis with normal CRPs and ESR, think that you could be looking, especially bilateral. You don't have bacterial osteomyelitis in 2 legs. Think it could be non-bacterial osteomyelitis, and then we can take it further. What about this child? Same story, 18-month-old boy with low fevers now. Now CRMOs don't have fevers, but they can have occasional fevers. Same refusal to walk, pain on touching, so more of periarticular, not articular. Counts P20L65, CRP20, and very surprisingly, they went to a radiologist who reported the MRI as CRMO. And we started naproxen, but then there were enough clues on the blood test. ESR was 80, platelets were 1.5, P20L65, white cells 4000. And you can see the same lytic lesions. You can appreciate this wrist joint. And these were the full body MRI. You can see changes here, quite symmetrical. But what is this? Sorry? This is pakka leukemia. So suboptimal response to naproxen was one clue, and obviously the picture did not fit like a CRMO. So before calling it CRMO, please rule out TB, leukemias, etc. based on the pattern. Message is, I'm not saying you will diagnose a CRMO tomorrow, but your differential, once you ruled out TB and or a leukemia, you are looking at a non-bacterial osteomyelitis. Clue, high lymphocyte. Remember, unless you are less than 1 year, you are not allowed to be lymphocytic. No response to naproxen is often a clue, and obviously the very high ESR is generally against CNO. This was one kid who I thought 2-year-old ankle and knee with morning stiffness. What will you send? Revision. Quick. What's the diagnosis? Oligo. At the end of 1 year, she comes with this. Ankles are fine, but she comes with the medial end of the clavicle which is swollen. So when you see a medial end of clavicle, a mandible, these are very classical places where you have CRMO. And remember the S for sapho, one was synovitis. You can evolve over time. Treatment necessarily may not change. So this girl, I had called her as a juvenile oligo. At the end of 1 year, she developed a clavicle ka swelling. I think the only thing we remember about the medial end of clavicle is what? Figure of 8. I don't think I remember anything beyond that. The other is CRMO. If you see a medial end going on, so obviously TB is always a possibility, but this is invariably a CRMO, right? I'll quickly go through. This was just one more kid with a mandible which was swollen up, and obviously it showed lysis. You ended up a biopsy, put them on the right treatment, and the swelling disappears completely. This girl incidentally 1 year back had a similar lesion in the sternum, which are unusual sites: sternum, mandible, clavicle. You just rule out tuberculosis and start thinking, is it CRMO? Easy, right? Perfect. And especially how many intensivists here, neonatologists, intensivists. If you see such kids in your NICU, bad psoriasis, psoriatic crash with deformed or osteomyelitis, the next 10 years we are going to see more and more disorders of innate immune systems, and one of them is deficiency of interleukin 1 receptor antagonist. These are fancy terms. DITRA is deficiency of interleukin 36. All of them are treatable with IL-1 blockade. But then this is a child who probably will be referred to a dermatologist who will call this psoriatic and do a lot of PUA therapy, blah, blah, blah. But we will ignore the bones and stuff like that. So in the NICU, if a newborn is running fever without any focus, once you have exhausted the sepsis part of it, think that you could be looking at a periodic fever or an auto-inflammatory disorder. What's this? This was an 11-year-old boy who was referred as poly-JIA. Very, very symmetrical arthritis. And does he look like an 11-year-old? What's an 11-year-old boy likely to have? Which type of JIA? 11-year-old boy. See, I told you I won't be able to catch Siddheshwar, no? लेट हो जाएगा करके, क्योंकि लोग आंसर ही नहीं करेगा. जल्दी बताओ. 11-year-old boy. B for boy. And correct. उसमें, but then this boy had ESR of 10 with 15 joints plus consanguinity, and he doesn't look like a 11-year-old. So when you start seeing such symmetrical joints with normal ESR, वो शिद्दत से बनाया हुआ like Taj Mahal, even the best of polyarticular JIA will have a little asymmetry. This is very, very symmetrical. So what are we looking at is, you will order a skeletal survey, and then sure enough you will find out basic anthropometry will tell you this is short trunk dwarfism and not short limb dwarfism. Short trunk dwarfism will document, what are you seeing on the X-ray? Very classical, platyspondyly, right? So bullet shaped vertebrae. Had he been dysmorphic, we would have called him MPS. If it's not dysmorphic, you will call it progressive pseudo-rheumatoid dysplasia or spondyloepiphyseal dysplasia, SED. Spondylo is spine, epiphyseal is bones, and dysplasia. This was one more kid again. Once you start seeing these kind of very, very symmetrical stories, this child was born normally, but over age 4 or 5 started contracting like this without any stiffness. Right? So JIAs will have stiffness for years and years and years before they start contracting. And JIAs will have ESRs of 10, not 10, 100 polyarticular ones. And this child actually has elbow also, knee also, and very peculiarly she had pericardial effusions at age 3, 4. Recurrent effusions with ESR of 10 and 15 and consanguinity. So the important message is history is important. You may not know the diagnosis upfront, but recognize the pattern. Once you start seeing the fingers tomorrow, you will remember, हाँ या तो polyarthritis है या तो genetic है. ESR 10 है तो genetic सोचो. ESR 100 है तो RA factor भेजो. Correct? Even if that level of stimulation has happened, I think this visit is successful. And then because the hips, she came to me because she was finding it difficult to get up also. Is this X-ray of the hip normal? You think this angulation is normal? Perthes is a good thought. Perthes generally happens in the younger age group, 4, 5, not a 12, 13. Is this angle normal? So is this neck shaft angle normal? It's more of a coxa vara, correct? So coxa vara, and this, when you see fingers like this, the medical word for bent fingers like this is called as, claw and camptodactyly, right? So remember, we will call this camptodactyly is bent PIPs, correct? So camptodactyly, coxa vara, and pericardial effusion, right? And this is, this is a coxa vara. So this is very similar to this. This is a normal and this is valgi, right? So when you see coxa vara with campylodactyly and pericarditis, start adding up, you will see this genetic condition called CACP syndrome. Again, can be proven genetically, and this is a child who was receiving methotrexate without any use because it was actually a genetic condition and not a inflammatory condition. So the idea is, once you offer a diagnosis, first good thing is you are stopping a potentially lifelong immunosuppression and then giving them some reasonable evidence that this child will only need physiotherapy, etc. till a time she decides. So she ended up having a pericardiectomy also because of recurrent pericarditis again and again. But then she's perfectly fine. So when you see such symmetry with normal ESRs, please do a skeletal survey, try to fit them into a skeletal dysplasia, get the genetic guy involved because they are the ones we can diagnose, but they are the ones who give concession for all the genetic studies. If you find one, and then we can crack the diagnosis. So we'll quickly move again. The next 3-4 slides are about this new age of diseases that I think all of you should know, auto-inflammatory disorders. So this is a 5-month-old. I told you newborn period onwards, if any child gets fever, you guys please stay awake for the next 3 minutes. The next session you can sleep off, whoever wants to. Important slide. Fever since 1 month of age, urticarial rashes, lymph nodes, dactylitis, diarrhea, HB7 counts 19,000, platelets high, ESR high, ferritin high. Where have we seen this kind of a CBC before this? Sorry? SOJI, correct? So, but then the age is 5 months. Had it been 15 months, SJIA. 5 months is something where you will start thinking of the term for auto-inflammatory disorders now is inborn errors of immunity. So we all know that there is innate immunity and there is adaptive immunity. So the innate immune disorders generally present in the first 6 months of age usually. And when do I think of autoinflammatories? When you have an SJI like picture, so young age of onset with a febrile illness, with rashes, and it has spontaneous eruption of your immune system. Suddenly this child have periodic fevers, continuous fevers, with SSC examination is the right way to remember. S for synovitis, S for serositis, C for cutaneous or rashes, and occasionally you will have uveitis. And in between the child will be normal. And then there will be a consanguineous history, and many of these kids can present with macrophage activation syndrome. And then there is a list of all the diseases. I can go through it maybe if we have time later on. But then this is one joint which I should show you. This was a child who was referred to me from Solapur. Age now when I see this child is around 4-5, but this is fever since infancy. 8-9 months se fever chalu hai, and he's got this. This is articular or periarticular? You will stick with me for the full day. This is periarticular. You can see this boggy synovitis, no? Articular or periarticular? Loudly. Articular, right? And then this is very, very boggy, Boggy is very, very bulky synovitis. And then fever is in early infancy. Now comes with joints. And when you see the skin, to the busy pediatrician and the parent, हे असंच आहे आमच्या घरात ते ड्राय स्किन असतोच सगळ्यांना. व्हॉट्स द मेडिकल वर्ड फॉर सच अ स्किन? एक्सेलेंट, इक्थायोसिस. बहुत बैड लक होगा कि इसको फीवर भी है, इक्थायोसिस भी है, जॉइंट भी है. एंड देन प्लीज पुट द टॉर्च ऑन द आई ऑल्सो. वी से ॲ करा अँड सी द टॉन्सिल, बट ॲ केलं तर गम्स बघा वी शिकलो, पॅलेट बघावी शिकलो, पण डोळ्यांमध्ये पण टॉर्च मारा. And this is, you don't need to be an ophthalmologist. What's wrong with that eye? Can you see? What's this? Sorry? Perfect. But what are you seeing here? This is a festooned pupil. The pupil is stretched, suggestive of chronic uveitis. Correct? And then what's the diagnosis is when you have rash, arthritis and uveitis. So JIA होता तो मैं क्यों बताता? You guys are experts in JIA now. I said fever नहीं आना चाहिए JIA को. Sorry? 4 साल से reactive. Sorry? Sjogren is next chapter for you. Think of autoinflammatory. कुछ तो गड़बड़ है. And then I'm saying you RAU. Rash, arthritis, uveitis. And remember, when you see such boggy synovitis, bulky synovitis, what will you think of? Something is wrong in that synovium which is causing it to be boggy and bulky. What can be there in a boggy and bulky synovium? Granuloma. Just see, if I say there is granuloma on the biopsy, excellent. Who said sarcoid? Who said sarcoid? Someone said no. Haath utao. You can go. You can go home and enjoy your Sunday. Sarcoidosis at a young age is called as what? If you answer that, then we will christen you as the next big thing in Solapur. RAU के साथ something rhyming with RAU, Rao is what? I sent this child to the eye doctor, tell me what I am seeing. He sent me this image and he said this is very classical mutton fat keratic precipitates. We've heard about it somewhere, no? So diagnosis was sarcoid, but a young age sarcoid is called as Blau syndrome. Okay, BLAU, Blau is early onset sarcoid, again genetically proven. So remember the clue, it's about connecting the dots. Young age, Ichthyosis is a very classical presentation of early onset sarcoidosis, correct? You will not have lung involvement. This is one of my friends in Chennai. This is a very typical Tamil family which comes, ऊपर वाले का कर्स है और हमारा पूरा खानदान का उंगली ऐसा है, and it was labeled as genetic, but this was a familial Blau syndrome, and the kid has such florid uveitis. So the child might come to you for some other reason, बगा ना डोळे, and the typical thing is पता चला कि वो LV प्रसाद जाके आपके पास आएगा uveitis का रिपोर्ट लेके. When you see any uveitis or a squint, do not dismiss this child. Think is it something rheumatology. We thought early onset JIA, ANA positive को uveitis हो सकता है. These are rare things but possible. You sometimes have to do a reverse connection, means you just see what's there. The child is showing you, but are you really looking at the ichthyosis? वो क्रीम तो माँ बाप भी लगा रहा है, but क्यों आ रहा है ये सब? Subtle clues, but then give them methotrexate and the child is now 6/10 vision at least and getting better. And the same things like what looks like SJ. So depending on the history, 3 days fever, 4 weeks normal, 3 days fever, rash like this is familial Mediterranean fever. Same thing. This is the Solapur kid I was talking about. Unfortunately, we lost this kid. IGD is the diagnosis, hyper IGD. This child since 1 month of age starts to have these urticarial rashes, digits causing dactylitis, and then lymph nodes, and then this is called as hyper IGD. 7 to 10 days fever, 3 to 4 weeks normal, again 7 to 10 days fever, again, right? And these kids can be managed with IL-1 blocks, etc. This is, I think many of you have heard of Sinca syndrome, right? So again, here the fever comes, Sinca is chronic, infantile, neurocutaneoarticular. But the clue is when you start seeing early infancy fever rash and you see legs like this, just take home this photographic memory of, a patella which is jutting out like this. This is an inflammatory patella. You do an X-ray. X-ray will look like rickets. But then it is not rickets. It is the patella which is inflamed. You will end up diagnosing Sinca. Correct? You don't need to diagnose Sinca. You just need to suspect Sinca and then just refer them. This, instead of 3 days or 7 days, this is a fever which goes on for 3 weeks. And for 3 weeks in a month, this child has fever and periorbital swelling. Okay? And then patient भी diagnosis देता है सापा सारखा rash येतो, सापावानी rash दिसतो, which translated to English is a serpiginous rash. And serpiginous rash with 3 weeks of fever, you end up diagnosing something called as TRAPS. So tumor necrosis factor receptor associated protein. So a bad gene causes a bad cytokine which keeps on firing again and again periodically. And many of them can be genetically proven, and this is TNF alpha, so you block TNF alpha. And this child is happy. When she is sick, she is like this, and when she is happy, she is like this. And the problem is she sees me with this condition, and she sees the pediatrician with this condition. And ऐसा कोई सगा नहीं जिसको हमने ठगा नहीं. पहला वाला मॉक्स देता है, दूसरा वाला मेरोपेनम देता है, and एक GP है ज्यांनी इथे एक इंजेक्शन दिलानी ती एकदम चांगली झाली. And you can guess what that injection in the bocha is. वो उसको dexamethasone मिलती है तो she becomes very happy. But you put this child on adalimumab or etanercept, they do reasonably well. If you do not do this, they may end up with amyloidosis, macrophage activations, etc., etc. This is the last slide on this session. This was a child who was referred as SJIA or systemic arthritis at 2 years. High fever since 6 months of age. And, very peculiarly, she was given ibugesic, but, and she had this livido-like rash. And see this video that the parents sent me. What are you seeing? There's something wrong with her face. She has a facial palsy. Not once, but she's got 2 episodes of facial palsy, and I almost thought she's not moving that side of the hand, that side of the body also. So she's probably has some monoparesis or hemiparesis, lividoid rash, and even on 10 mg of steroid, she was spiking. So when you start seeing strokes, recurrent episodes of strokes or recurrent episodes of Kawasaki in a patient or medium vessel vasculitis, you will end up diagnosing something called deficiency of adenosine deaminase 2. Again, it's not a very uncommon or a fancy thing I'm showing you. When you see strokes of unexplained reasons, especially in NICU, once you've exhausted your homocysteine and antiphospholipids, etc., you may end up, especially if it's recurrent, you may send a exome sequencing and you may end up diagnosing DADA2, which is important because this child will do very well and is doing very well on TNF alpha blockade. So just think that rheumatology can come in different ways. या कुछ समझ में नहीं आए तो रूमेट के बारे में सोचो. It may not be tailor-made, but if I am having cranial nerve palsies and I am having fevers and I am having joint, इसी को अगर fever के बिना Bell's palsy हुआ होता and uveitis आया होता, then you would have thought of sarcoidosis. So many things you just have to think about before labeling them. Very common OPD situation. 10वीमध्ये एक्झाममध्ये 10 दिवसात सांगायचं आहे की पेशंट एक्झाम देणार की राइटर. आई डोंट नो, आई एम श्योर दैट कंसेप्ट इज देयर हियर ऑल्सो. CBSE ICSE में बच्चे से लिखा नहीं जाता तो बच्चा पढ़ेगा, रट्टा मारेगा, राइटर को कान में सुनाएगा, राइटर इंटरप्रेट करके लिखेगी. फॉर द सिंपल रीजन दिस चाइल्ड हैज़ अ वेरी स्लो स्पीड.
Getting lot of ancient things. How many of you hold the pen like this?
While you are folding the pen. So this is again, I have this arachnodactyly behind. So many of these kids who are super flexible and hypermobile find it difficult to hold the pen with a proper grip, right? And a simple thing is the occupational therapist should give a fat pen to write and practice and a sloping bench like our generation used to. Because they are writing in cursive with a patla sa Reynolds ka pen, they can't finish the paper. When they write, they have lots of cramps. These are mechanical issues, and this girl will come to you at age 5-6 with growing pains, at age 10 with शाळेला त्रास होतोय, age 15 with low back pain, etc. And these are very common things, mechanical issues. I'll just skip this. This is called Gorlin's sign. Have you heard of Gorlin's sign? The tip of the tongue touching the nose. So I thought I was very clever and I made these 3 kids happy by showing them their superpower. This is any muscle is very, very flexible, and very peculiarly if you have a girl who's born on 16th of October, and both these kids were 16th October. 16 October के बच्चे के tongue, she said I can do better also. So she did this maneuver and showed me. I mean, it's not rocket science, it's just hypermobility at its best. And it's a spectrum, someone will have growing pains, the other end is Marfan syndrome. And this was a kid I saw in Australia. Every exam, if someone had to fail a candidate, ye case mil jata. There is no bimari where you can do all these fancy things. How many of you can do this? एक leg Solapur की तरफ, एक leg Chennai की तरफ. Literally the hips are rotated 90 degrees. And then these 2 kids would just dislocate the shoulder on a weekend, come and have a nice time in the casualty for the full day. Plastic surgeon शाम को आएगा तो nitrous oxide सूंघा के हंस रहे थे दिन भर. And the minute the surgeon used to come, they would pop it back. And we are happy. It was a pure mechanical story, and they were proven Ehlers-Danlos hypermobility variant. Why did they do this? Because they are flexible. But then you realize a lot of psychological things were happening. The family dynamics was going for a toss. Husband had a extramarital relationship. Wife was jobless, etc., etc. They used to just do it for fun and trouble everyone, and to the untrained eye, अरे डिसलोकेट हो गया, सर्जन बुलाओ. इंडिया में शायद ऑर्थोपेडिशियन आ जाएगा तुरंत. वो ऑस्ट्रेलिया था करके वो 6-7 घंटे के बाद अपॉइंटमेंट लेके आएगा. बट देन यू हैव टू बी, इट्स अ थिन लाइन बिटवीन ओवर डूइंग things and underdoing. I should not have given you the diagnosis, but is this articular or periarticular? Sorry? This was a child who was referred to me with some joint swelling. This is periarticular, no? इतना ऊपर थोड़ी joint होता है. And then obviously it turned out to be rickets. So common sense should also be there when you are seeing patients. This child was a rickets. What happened to this? How many of you said this boy is JRA? None of them, no? But he was 14 years. What's his weight, you think? 100. And he had his eyes also. He started from the western suburb and came. Every hospital he used to spend 5 days, 6 days. He's got everything from Solumetrol to EFG to NCV and neurologist, everything. Finally, घूमते neurologist referred, तेरे type का कुछ तो है क्या देखो. Before the anesthetist had already injected his ganglion for pain relief, everything that you can think of, and nothing came out, you know. And then I just sent this boy out and was looking at him in the camera. He was happy outside. He was carrying the latest iPhone with a gold ka bracelet. And I just listened to the mom for 1 hour. And the symptoms were very bad, but you examined him, he was probably malnourished in a different way. Very well-to-do family, but turns out that this boy was weak. Sorry? Malingering is a good word. We will call it pain amplification syndrome, because malingering parents don't like. मेरा बच्चा तो दूध का दूल्हा है, acting नहीं करेगा, you know. And then the boy was weak in English. He had तारे ज़मीन पर का problem, so he had dyslexia. माँ बाप बोले कि तू जा एग्जाम को, लेकिन लिखा नहीं तो भी चलेगा. Easier thing would have been go to a developmental pediatrician, remedial education, and say don't go for the exam. तू गुजराती है, धंधे पे लग जा. But he used to go to the exam. Father had a big business loss. He was a diamond merchant. His stocks crashed. Mom and dad used to fight every day at home. And the only time they used to be together was the hospitals. वो फ्री में वो बेल बजाओ, घंटी दाबाणी, फ्रेंच फ्राइज येणार, हे येणार, because all throughout his ESRs were 10, right? I said stop all the medicines and put him in a rehab program, and this is the same boy after 3 months of stopping pregabalin, gabapentin, nortriptyline, everything, and just put him in a rehab and exercise. He's lost weight, he's become thinner and fitter, and this was actually, you know, so दिसतं तसं नसतो का logic was, this was a living example. And this mother has, I think, become her latest DP says she's a tarot reader now. And she's happily selling rings for patients or people who have numerological issues. Very strangely, but they are happy now. And this boy is doing perfectly fine. So there's a thin line between overdoing things and underdoing things. So what take-home message is? Arthritis, acute, subacute, chronic. Acute and subacute is more of pain, less of swelling. Acute monoarthritis, please rule out sepsis. 2 weeks may rule out tuberculosis. Acute polyarthritis is never septic, often reactive, rarely sinister. Chronic arthritis, I told you, is more of swelling, less of pain. Chronic monoarthritis, rule out TB, rule out malignancy before ruling in JIA. And chronic arthritis is almost never septic. Sometimes you may have malignancies. Mostly you will end up rheumatology. And the chronic arthritis takeaway is very easy. 2 साल 2 joint, ESR 2, A for ANA, juvenile oligoarthritis. Think of uveitis. 12 साल Bara joint, high ESRs, think of a RF positive scenario. Lower extremity joints in a boy, think of ERA, send a B27. Young age with dactylitis, see and think for psoriasis. Last but not the least, eye check. So, end of chapter 2. No questions, we will go further. We have to go fast, I think, no? Oh, is it going okay, or is it a bit too hi-fi, or is it a bit slow? You want this to get over? No answers. You can be rude at me also. You don't need to be nice. Better to end the... So CTD we are going to discuss next. Autoinflammatories, the issue is there are classical presentations of diseases which I had a few slides which you can go at length aram se at home. To the TRAPS, the Cinca, the familial Mediterranean fever, DADA2, Blau, all of them have fixed genetics. They are not connective tissue disease. And the clue is simple. Connective tissue disease is adaptive immunity. So later age group. Autoinflammatories are innate immunity. So young age of onset. Adaptive is autoantibodies. Young age is cytokines because they don't have antibodies yet. So the SJI now is going to become a part of autoinflammatory like a Kawasaki, because KD is similar to SOJI, young age of onset, no antibodies in them, versus a lupus which is 13-14 years, has a anti-dsDNA antibody. So that's the way to understand a very young age with innate immune system will produce more cytokines is autoinflammatory. Slightly older age, which the patterns we are going to see in the next few slides, is going to be connective tissue disease. People are walking out of this room. You want a break or we'll continue? 10 seconds break. Sorry. 5 minutes break. I have Alia Bhatt for you only. Please walk in quickly.
Once again, I welcome all of you. We will have two more sessions on the rheumatology. I request Vijay sir to proceed.
It's good. Okay. How many of you sleepy? I think Alia Bhatt को देख के आँख तो खुलना चाहिए ना सबका. I borrowed this concept from a hemat-onc colleague of mine who says, I think there is a lot of similarity between rheumatology and the air hostess. We generally come with the impression that we will have a glamorous air hostess, but then we end up with someone who keeps doing physiotherapy every time, asakara, mask kenar, he kara, and we are hardly looking at them. And the importance of all this will come only when there is a turbulence or your flight gets into trouble. The same thing is like rheumat, घर में जब तक rheumat आता नहीं है या सामने आता नहीं है, you will never think about it. But the minute you start seeing, a simple example is a kid with a Raynaud's phenomenon. अरे रूमैट था ना, शायद लेक्चर में सुनना चाहिए था. I was focusing more on the chicken outside, and so it's just one slide to keep you aware that collagen vascular disorder. So the first tip for now is don't use these words loosely. Rheumatology is not collagen vascular disorders, and collagen vascular disorders are not connective tissue disorders. They are not interchangeable, or each one is very, very specific, right? So this is one more thing, most of the, I'm just waiting for 2-3 people to walk in, just 2-3 slides because we'll do the next things a bit. Do we have time till 4? Because it's already 3. 1 hour, no? So 3:45. Perfect. So ये हाथी को मैं भगा देता हूँ, जाने दो. But ये तो सुनना चाहिए ना. The elephant in the room is the prototype rheumatology, because the patient will never walk to me with a complaint. They will come to me from various specialties, ICU, hemat, neuro, endo, etc. And then I'm fond of these 4 alphabets that we've learnt in medical college. The first one which we learn is idiopathic. काय झालं माहीत नाही, कशाला झालं माहीत नाही, काय करायचे कदाचित माहीत असेल. From there, the next word we learn is iatrogenic. All of us are iatrogenic throughout our lives. Keep medicines. Few of them will become idiosyncratic. They will throw a rash, like I'll show you in the next few slides. And the idea of this presentation is, end of the day, you should not look like an idiot. Gone are the days when you could have got away with these 4 words, because post-COVID, the elephant is the same, but our awareness and understanding is changing. And we are starting to use terms like innate immune system, inflammasomes, interleukins, etc., and molecular diagnosis. And 5 years from now, I think with all the vaccinated kids, you will start looking at possible biomarkers, and the whole world is going to change. For a start, let's start with this kid. It's just going to be pictures with a little bit of messages here and there, right? Even if we don't do vasculitis, we'll always plan vasculitis online, because I don't want to rush through this, because this is important. This child was again referred to me by a pediatrician. तेरे type का कुछ तो है, 6 महीने से joint pains हो रहा है. 10-year-old girls with upper and lower extremity joint pains. What is the commonest diagnosis you will think of from what we've learned so far? 10-year-old girl, upper and lower extremities, joint pains. Poly-GI, excellent. But she also had, what's morning stiffness suggestive of? Excellent. So she came to me with this, and I don't know if you can appreciate this. Can you see something wrong with her fingertips? Does it look too pale? And then this is what happened in my consulting room. Can you see these fingertips? It's suddenly becoming a bit bluish, right? And then you start looking at her nose. It looks slightly, popat nak, but there was nobody with a popti nak in the family. This girl looked like a bit of a pointed nose with Raynaud's. And the history when you take, she says, 6 महीने से उसको खाली बसून उठायला खूप त्रास होतो, weakness आहे, खातच नाही. And then Raynaud's was the added thing. And then when you observed her closely, this is how she got up. Not the best Gower sign, but I don't think anyone gets up like this. Especially when you ask them to get up 3 times, she was having reasonably some difficulty. And look at her eyelashes. What's this? Violaceous rash. So what do you think she has? She looks like a JDM, and JDM can get arthritis. But why Raynaud's in a JDM? JDM को Raynaud's नहीं होता है, right? Which connective tissue disease has Raynaud's? Crest, usually seen in adults, but the pediatric counterpart, which we'll see, right? And you do the basic tests, What's the basic test that all of you will do from tomorrow with or without my magic pen? And pen will not stop till you finish creatinine, SGPT, ESR, CRP and CBC, correct? And because I thought that she had difficulty in getting up, I sent muscle enzymes. And this was the report. There are 4 muscle enzymes, SGOT, CPK, LDH, aldolase. Remember, do not say only CPK and stop. Send all of them. So her enzymes were slightly high, and the classic combo CRP negative, ESR high. Now what? SLE, good. SLE, JDM, crest. So what's this khichdi about? So she has a skin, heliotrope. She has kind of, if you see these fingers, it looks a bit contractured, See this and this. Slightly, she has a kind of a clawing. And she has Raynaud's. And she has myositis. And she looks like a leukopenia with a bit of CRP negative ESR. So she probably is exactly what you guys told me. SLE with a JDM. With scleroderma is probably the right word instead of a crest syndrome. And she's come with RA-like symptoms. You only said poly-RA. So when you have these 4 or 5 things, you will start off by thinking of a condition called either a mixed connective tissue or undifferentiated connective tissue or an overlap of 2 conditions, right? So what's the difference? But you will anyway do an ANA, right? An ANA came 1 in 3,200, which is very high. And you sent an ANA blot and she tested positive for an antibody called anti-RNP, that is ribonuclear protein, which is very, very specific for a condition called as mixed connective tissue disease, right? So even I didn't know what happened, but the kid came and started showing me things. The pediatrician saw it rightly and referred to me. I could not stop at seeing. I started looking, and then it's just a bit of nitpicking, spending time, and things will flow. It's just about connecting the dots and asking for time, right? The problem is patient के पास ही time नहीं रहता है, डॉक्टर किती वेळ बोर करणार, कधी आम्हाला पाठवणार, but it all takes time. So let's start with the definition. When will you use the word connective tissue? Anything which affects the connective tissue. What's connective tissue? Skin, bone, muscles, joints, and blood vessels. Correct? I won't touch the non-inflammatory part. The non-inflammatory involves the Marfans and all those things. But it is an immune-mediated systemic inflammation affecting connective tissues. For all practical purposes, these are the only 5 connective tissues disorders which we encounter in day-to-day practice. So SLE, myositis, dermatomyositis or polymyositis, systemic scleroderma and MCTD. Some people involve the RA in the whole story, right? So exactly what all of you talked are what they can, if they come in groups, you call it overlap. If they have a specific antibody, you call it a mixed connective tissue. And what's undifferentiated is they have little lupus ka features, little scleroderma ka features, little myositis ka features, but they do not have a specific antibody positive on a blot yet. So this is undifferentiated, which means आज नहीं तर उद्या नहीं तर परवा, it will differentiate into one of either of whatever we discussed. If you have features of 2-3 diseases but no antibody on blot, it is undifferentiated. If you have features of SLE and RA, it is overlap. So rheumatoid arthritis with lupus is called Rupus. It is a known entity. And if you have a specific antibody with the khichdi, like an RNP, or if you have an RNP positive, it is MCTD. If you have an anti-Rho and La, you become Sjogren, which can look like lupus Sjogren overlap. And then you can have myositis Sjogren overlap, etc., etc. But the important message is pick up the signs and think whether you might be dealing with the UCTD or MCTD, etc. So this is the repetition. This is only the 5 diseases that we usually end up seeing. This is an easier way of remembering when to suspect a connective tissue disease. I call it CONNECT. C for anything that's constitutional. We know all the constitutional features of SLE. O for organ affection, multi-system inflammatory. R for Raynaud's. R for Raynaud's nahi hai, but N hai beech mein kahin to. So when you start seeing Raynaud's in a place like Solapur, you should be worried. Even in Maharashtra, if we see Raynaud's, it's a problem. Because invariably, we don't have extreme cold. तो सोलापुर में रेनॉल्ड्स दिखा मतलब you will think primary है कि secondary है. Rarely you might see nail fold capillary changes, some subcutaneous nodules, calcifications, etc. Elevated muscle enzymes like we saw, and cutaneous, so skin is often involved in many of these, which I'll show you through pictures. Last but not the least, if you start seeing once in a while skin tightening, etc., keep thinking of scleroderma, etc. All of this against an inflammatory backdrop will make you wonder, am I dealing with a CTD? This is an important slide. कुछ समझ में नहीं आया तो भी a detailed head to toe examination, a scalp which has hair fall, hair loss is lupus. Go down a bit, eyelids, eyelashes, you have heliotrope and edema. Red eyes is Sjogren syndrome or dryness, as I'll show you. Butterfly rash in SLE, malar rash of JDM, vasculitic ulcers, hard palate ulcers like we'll see. Lips, mucositis can be seen in SLE. You have rash on the shoulders, trunk. You can think of JDM. I'll show you pictures about all of them. Lower extremities, palpable purpura in Solapur with fever is rickettsia. Without fever is HSP. In an adolescent girl, think of lupus. So this is a broad thing which will take you to the chapter, right? And this is for people who have not seen any of the connective tissues. This is the picture. You can have alopecia, the classical malar rash. These kind of infarcts involving the ears can be seen in lupus or dermatomyositis. If this is not a conjunctivitis and your eye doctor calls this as scleritis or episcleritis, think that you could be dealing with a Wegener's or a lupus-like story. Always remember to see the hard palate ulcers when you open the mouth. You can see the heliotrope rash here. Dental caries in an older child with an ESR of 120 should ring a bell that this child probably has dry mouth. I'll show you pictures. Raynaud's we have seen. If you see fingers like this suddenly, infarcts and gangrene, it's a vasculitis or a connective tissue. When you see legs like this, it's a small vessel vasculitis. Gottrons, we all know, need not be only on the knuckles. You can have gottrons on the elbows. This rash on the shoulder and trunk is called shawl sign. I'll show you more pictures. And this I'll show you later on, right? The next thing is there are some packages which are very, very ready-made. And these generally are standard packages like we seen before. Anemia, leukopenia, lymphopenia, thrombocytopenia, negative CRP, high ESR is lupus. Normal counts with high muscle enzymes, JDM. Negative CRP, high ESR, har din ratta maro, think of lupus. A negative CRP, mild, high ESR, JDMs generally don't have a high ESR. ANA positive, DSDN, agar bheji diya blot, then these combos will also come handy. If you have a double-stranded DNA Smith positive, low C3, C4, invariably you have lupus, no differentials. If you have a DSDNA negative but ROLA positive, RF positive, it sounds difficult, but you don't need to ratamaro for everything in one day. Just read one line every day, and then it will really fit in. And the first kid that you diagnose will probably set the ball rolling, as I say. Again, no prizes for guessing this. Revision. What am I hinting at? What are these suggestive of what blood tests? You can never separate Kadipatta from Dhania, Jay from Viru, Sachin from Saurav. And the only thing I keep selling, I have used all examples, Tom and Jerry, Amit Shah, Narendra Modi, Solapur and Shenga Chutney. Wherever you go to any dhaba or restaurant in Solapur, your Shenga Chutney is universally omnipresent. So CRP and ESR, please. ये भी याद रखा आज के lecture के बाद. I am more than happy. What happens in the election? Please send a CRP and ESR whenever in doubt. At least a normal thing will reassure you. Correct? I am not a big believer in criteria. Do not refer to any criteria for diagnosing rheumatology, because for every 3 things which are positive, 2 things will be negative, like our parliament. Diagnosis is made clinically and all the criteria are for research purposes. They are not diagnostic criteria. Quickly let me run through this. Easy diagnosis: 9-year-old boy with fever of 3 weeks, facial rash, oral ulcers. Can this be Epstein-Barr or herpes? 4 weeks ho gaya. Facial rash, pedal edema, and axillary cervical adenopathy, and HS megali. Sorry. If we pretend to be Amdekar sir, which system is involved? With HS megali, lymph node, reticuloendothelial. Excellent. And PUO. 3 weeks you have obviously ruled out all of them. What can cause pedal edema with fever? Can you have a 9-year-old with nephrotic syndrome? You can, but it's an unusual age, correct? So something to do with the kidney and fever. So straight away the minute you start thinking, देखेगा तो गांधी जी भी दिखते हैं ना वैसे, this is lupus for me. It should strike a bell at least. And then if the child looks like this, unless you are thinking of lupus and seeing, oh, this is not acne conglobata. A few of you will think ये acne conglobata है क्या, sappho है क्या, but common things are common, right? And मुंह खोला तो I'm sure all of you won't see the tonsil tomorrow. You will see ऊपर कुछ है क्या, and ऊपर बहुत कुछ दिखता है. This is that typical hard palate erythema or ulcerations that you will see. And what do you expect in the blood tests? Pancytopenia, bicytopenia, CRP low, ESR high. That side is 2, this side is 0. Scoring system. Hands might show some vasculitic infarcts, Raynaud's phenomenon, and obviously, like we discussed, this is a very classical, counts 20,000, platelets 6 lakhs, ESR 110, diagnosis systemic arthritis. Counts low, platelets low, ESR high, urine showing sediments, it is lupus. Easy. How will I screen for lupus? Once I suspect lupus, this is the only thing I want pediatricians to send. Please don't make the patient spend money on ANA blot. Even if they don't pay me, by the time they reach me, they have run out of money. The only test I ask is a blot. Uska paisa nahi rehta hai patient ke paas. If you do this, a low C3, a low C4, and a PC ratio more than 0.5. If I am a nephrologist, my value of more than 2 is nephrotic. If I am a rheumatologist, a PC ratio of more than 0.5 is significant. A PC ratio of 0.5 means 24 hour में 500 milligrams. That's the definition of proteinuria in lupus. PC ratio 0.1 equals 100 milligrams in 24 hours. PC ratio 0.2, 200. PC ratio 0.3, 300. PC ratio 0.8, wrong. PC ratio 0.8 could be either 500 or 1 gram. Means the urine PC ratio has got a higher sensitivity at lower values. So lower values 0.3, 0.4 I am okay, but if it comes 0.7, 0.8, I might be interested in quantifying the proteinuria. Gold standard is still a 24-hour urine protein. But do not disregard a PC of 0.8, etc. Correct? Then I will document an ANA by IF, and the significant titer is usually 1 in 100 or 1 in 160. So this will be high, and then you confirm the diagnosis with an ANA blot, right? And then obviously if the proteinuria, etc., you end up doing the biopsy, etc., and beyond the scope of our lecture. So this was one more kid who presented very similar to this girl. I think I showed you in the morning, right? Periorbital swelling, and she had distended abdomen and severe tummy pain, and got a sonography done. It was loaded with fecaliths. Okay, so 7-year-old girl with, she must be one of those unique girls who got a sonography to diagnose feces in the tummy. But she was constipated, big time. And the pediatrician saw the same pattern, leukopenia, thrombocytopenia, and then कुछ नहीं तो मुंह खोल के देखो, this is hard palate ulcers. IV घातल्यामुळे डॉर्सम मध्ये सुजते, बोटं सुजत नाही. हात सुजलाय का, हां डॉक्टरने IV टाकलेली. The commonest problem, look at the fingers. Fingers are also puffy. One finger puffy, dactylitis, reactive. 2-3 weeks, one finger puffy, TB. 3-4-6 weeks, finger puffy, psoriatic. When all of them are symmetrically puffy with a febrile illness, this is very, very inflammatory dactylitis. Can be seen in Kawasaki disease. Or this, in this story, this was obviously low counts, lymphopenia, low platelets, and again, what will come to your rescue is CRP and ESR. Negative CRP or relatively normal. Lupus as a rule is CRP naive, ESR high, right? And then obviously you do an ANA, C3, C4, and why do you think she was having constipation is many lupus patients have autoimmune hypothyroidism. So her TSH came as 100, very high, and you start giving L-troxin and she starts passing stools. So the patient gives you enough clues, then we become ISI, rheumatology, Mudrankit on steroids. She becomes puffy, and at the end of 1 to 2 years, she is completely into long-term remission. So the eyelid swelling could be because of a secondary Sjogren syndrome. She can have lacrimal gland adenitis, or people have described even subcutaneous edema. This girl was not proteinuria causing edema anyway. So one of those odd things who never, till date has never had a malar rash, correct? This is a very not so uncommon. You might see this kid who is a 13-year-old female. So if I don't, even without seeing the patient, when I see a 13-year-old female, the first thing which hits me as a pediatrician is as a TB. He's TB. Second is obviously lupus. But this girl has a history which is going on for the last 7 to 8 months, emotional outbursts, behavioral changes. She becomes tired. Mother thinks she's become lazy. Handwriting is going bad. She's dropping her pens. She's speech is a bit dull. And, she looks otherwise happy. And the pediatrician says, "Tu ekda paun geshil, kuch to gadbad hai usko." And it's a very sane pediatrician in Jupiter Hospital. So what am I trying to show you? What are you noticing something? What are these? Absolutely. So for the PG students, the commonest differential to get a passing mark is rheumatic. But practically, I think you will end up diagnosing more lupus in practice, because this girl, I said it looks very suspicious. And what is this? Jack in the box phenomenon, right? And this is, we've already seen that quasi-purposive, coriform movements. And what to expect in the blood test without seeing quickly. Anemia, leukopenia, lymphopenia, thrombocytopenia, negative CRP, high ESR. Easy. And then how will you screen? PC ratio 2.28 is a very high proteinuria. Then what will you do? Ignore the biopsy part of it. What will be the next thing you will send? C3, C4 will be high or low? Perfect. And then how will you confirm? It's an easy job, right? So you just think of lupus, screen, and then you confirm. So when do I diagnose lupus? Female fever, fatigue, most common. Don't blame it as an adolescent who's just fooling around. Cutaneous, you may be lucky to see the butterfly. When you see a butterfly or you suspect lupus, see for hard palate ulcers. Arthritis, unusual age of nephritis. You may have a nephrologist who's managing a 13-year-old as a nephrotic syndrome, but you will want to rule out lupus causing it. Especially hematologists, if ever you are crucifying anyone to a diagnosis of chronic ITP or autoimmune hemolytic anemia with thrombocytopenia, Evan syndrome. The minute you start hearing all of this, if your spouse is a gynecologist and they have girls who keep coming with menorrhagia for no reason, right? So many of these kids eventually will end up, नहीं हमारे तो नसीब में 20,000 की ज़्यादा प्लेटलेट जाते ही नहीं हैं. That's the way these patients are tuned. Please rule out SLE as the mother of all autoimmune disease. Anytime you hear autoimmune, whether it's hepatitis, encephalitis, thyroiditis, please rule out the main autoimmune disease, which is lupus, right? And obviously unexplained encephalopathy, chorea, or the involuntary movements you've seen, you will think of lupus. How do I think of lupus? These clinical things with anemia, lymphopenia, thrombocytopenia, negative CRP, high ESR. How do I screen ANA, C3, C4, PC ratio? How do I confirm ANA blot? It's a very easy job. What's this? 35 minutes hai hamare paas. Quick. What's this? Enoxonlin purpura. Why will I show you an HSP in a connective tissue disease? So कुछ समझ में नहीं आता to see what the kids are wearing. Again, I have a habit of clicking t-shirts because my kids keep coming with such t-shirts, angry, hot skin, but the t-shirt says probably the coolest. The first one was a googly, it was JRA but turned out to be a Luke. So ऐसा कुछ discrepancy, I mean this is not evidence based, but how will I know if it's hot or cool? Same story. ESR 120, ESR 100. If I want 3 conditions in rheumat to be having normal ESRs, one of them is HSP. Because HSP is a vasculopathy. Second is a dermatomyositis. Again a vasculopathy. Third is a joint become, ESR become, age become is oligoarticular. Right? This is HSP like lesion, but ESR is 120. So they are hardly cool, right? So what's the history? The kid on the left hand was a 5-year-old girl whose mom came with this rash, and the skin specialist had said जरी induced dermatitis. जरी as in silk. जब भी silk कपड़ा पहनती है तो ऐसा होता है उसको. But it was a clever dermatologist only because he sent an ESR. And that ESR was 120, and look at the counts, 4,200 is slightly on the lower side, not earth-shatteringly low, but low. And the kid on the other side was a 10-year-old boy who has been getting these rashes since 4 years of age. You can't have HSPs going on for 6 years. And then he goes to a medical college, gets all the workup done. Usme bhi counts are low, ESR is high, but total proteins are very high. The advantage of going to a medical college is पूरा package हो जाता है. And then they said HSP है, उसका biopsy भी किया, उसमें small vessel vasculitis भी है, बोला अपने आप ठीक हो जाएगा. And the patient reached Jupiter Hospital saying उसका कोई तो सगे वाले ने बोला Jupiter में जाओ कोई तो मिल जाएगा. And thankfully that कोई तो was me. And then when you start seeing this child, this was same problem. When problem is in Kerala, look at Kashmir for solution. The kid on that Jari allergy side had red eyes, which was blamed on environment allergic conjunctivitis, and they were happily putting steroid drops. And the kid on the right had, why should a 10-year-old have bad dental caries? So that was one clue, dental caries. And then this, and the history was that the 10-year-old had a recurrent parotitis also from age 4. Excellent. HIV to pass the exams, but you can't live with HIV for 6 years. But Sjogren's is, remember Zika syndrome is a disease of a 55-year-old, not a 5-year-old. So the 55-year-old will have all those dry eyes, dry mouth, etc. This kid gave you enough evidence of a dry eyes and a dry mouth. And the clue is when you see high proteins in inflammation, you call it hypergammaglobulinemia. And one of the things we have remembered reading from pathology textbook is what? Waldenstrom's हाइपर गैमा ग्लोब्यूलिनेमिक पर्प्यूरा. कहीं तो कोने में है, बट वर्ड वॉल्डेनस्ट्रॉम तो सुना है हमने, करेक्ट? सो एनी टाइम यू हैव अ हाई प्रोटीन लेवल्स with purpura, remember Sjogren syndrome is a hyper gamma globulinemic condition, which explains why many Sjogrens will be Ra positive also. Why? What is Ra? That's an immunoglobulin. It's an IgM. It's an IgG directed towards an Ig. It's an IgM directed towards IgG. So along with other proteins, even Ra factor is high. So then, what's the clue? When you have HSP-like lesions, but dsDNA is negative, proteins are high, and dry eyes actually can cause red eyes, and dry mouth can cause dental caries. So when you have a 10-year-old with dental caries, you can't blame दूध पीता है और chocolate खाता है और brush नहीं करता है. It's the lack of saliva production which predisposes them, right? So it's just a matter of common sense. And sure enough, this child had an ANA and anti-Rho, anti-La positive, and the diagnosis is primary Sjogren syndrome. Take home message: red eyes is dry eyes. Caries in an older child with high ESR, think of dry mouth. Easy. I'll switch. Last situation is this: 5 to 10-year-olds, usually, it will start in the summers, and difficulty in sitting up or getting up from sitting position, rash, pain, normal counts, high 4 enzymes. What's the diagnosis? Some popular film actress's Instagram post was like this. She got divorced and she became famous. Samantha. Hashtag polymyositis. Right? So 4 muscle enzymes: CPK, LDH, aldolase, SGOT. Bhejo. Correct? And then very typically proximal muscle weakness. It might come to you from the neurologist. There might be a temptation for you to send them to a neurologist. You can do that, but always see 4 muscle enzymes. If in doubt, before sending to the neuro, please document the 4 muscle enzymes. Agar muscle enzymes high hai, you have to send them to a rheumatologist or a radiologist to get a MRI of the thighs done. What are these? Very typical, the periocular near the eyelashes. In India, we won't see a purple colored rash, but this distribution is called as a heliotrope rash. What's a heliotrope? It's a purple colored flower. So just see the areas, and you can see occasional vasculitic ulcers. The next thing you will see is a malar rash, right? How do you differentiate a lupus butterfly from a JDM butterfly? Excellent. So बच्चों को काजल लगाता है वाला रैश इज SLE. ऑस्ट्रेलियन क्रिकेट प्लेयर्स सनस्क्रीन लगाते हैं इज JDM. Perfect. So more pictures. Just carry home these picture images. You can have something called raccoon sign also. So the raccoon sign is in this area. And the classical Gautrons, you may see Gautrons on the knuckles, elbows, knees also. And with chronicity, you may start seeing wasting of the thighs. Good old days, Bohan and Peter will help you do a biopsy. But this day, we will image directly. When you are doing an MRI for myositis, please specify you want T2 weighted and stir sequencing. The stir sequencing will pick up all that is supposed to be black will be white. Easy. More pictures of Gautrons. This is there in that IAPICA atlas also. So these are the same pictures, right? And these are the myositis showing all the thigh muscles coming edematous. It will definitely show you myositis, and then you correlate with the rash and enzymes and symptoms. And remember, dermatomyositis is not just skin and myo, it is blood vessel also. It's not vasculitis, it's a vasculopathy. So you will have ischemic lesions, and you will see this punched out lesions. This is the classical inverted V sign and the shawl sign. And once you see one JDM, you will never miss any. They will all look the same. this is another child with a V sign. This is V and this is ulta, inverted V. For you, if you see VV, you remember VV. That should be easy. Bad joke. So hypoglycemia. What's the diagnosis? Quick. लिखा है ना, सब सो रहे हैं ना, जो खाया है वो भी सो रहा है, जो नहीं खाया वो भी सो रहा है. What's this? JDM, no? Perfect. Why am I showing you another JDM? Because when you examine this girl, this child has got some funny things in the arms. Stony thing, and one funny thing in her abdomen, which is very hard. So calcinosis cutis. Should you be happy or unhappy? Calcinosis is good or bad? Bad. So in 15 years back, we would have bitched कि अरे उसको कुछ आता नहीं है, वो बैठा रहा 10 साल, कुछ नहीं किया या ट्रीट ही नहीं किया. So delay to diagnosis would have been blamed, or and then when you do an X-ray, you can see all these calcium deposits in the subacute. So young age of onset, delay in diagnosis, inadequately treated, blah blah blah. In the current day of treatment, this is the same girl. I'll stop whenever you guys want to. No? Don't make me restless also. मेरे को लग रहा है कि सब घड़ी देख रहे हैं. तो this child doesn't want to get up because she has huge calcium deposits around her bumps, in the knees, and she was diagnosed at age 4 from Washim by an adult neurologist as polymyositis. And as usual, inadequate treatment, and now she comes to me at age 7. She just doesn't want to get up. So I obviously document calcifications, and then in the older times, you would have put her on methotrexate and steroids the conventional way. But this bad a calcification, this day and age, once you document, see, this is the big chunk of calcium in her hands. So we ask for something called myositis specific antibodies. Like you have ANA blot, you have myositis antibodies. So this package costs about 10,000 rupees. Please don't send it. But what it simply means is you have some antibodies which are genetic, which can be like the crystal ball, which will predict calcium deposition, predominantly bad skin involvement, predominantly bad internal organ involvement, so on and so forth. So this girl actually tested positive for anti-MJ positive. Again, not wanting to prove that we are clever human beings, but MJ positive is, which is the most popular MJ that you have heard of? I showed you one in the morning, no? Michael Jackson has all those weird movements, contractures. So think MJ positive आया तो calcinosis, contractures and bad skin disease. And this, why is it important? Because the minute she came back with the report, rather than using steroids, methotrexate, soup, roti, rice, we directly intensified to a dessert. So I straight away put her on rituximab and cyclophosphamide upfront. That is called as de-escalation, which is the new rule in rheumatology. We generally don't escalate because she's already become sick. And see what happens when you hit hard early. This is the same girl. The girl who was refusing to stand, with 3 doses of cyclo and rituximab, she is much better. I cannot reverse the calcinosis fully, but at least she looks much better. Otherwise, we would have wasted 6 to 8 weeks giving methotrexate. It would not have worked. The calcinosis would have worsened, and this child could have pulmonary involvement. This child could have internal organ involvement, which could have been potentially life-threatening. So when you see this bad calcinosis, even though you are sure that it is a JDM, it is best to, either pick them up early or refer them early, because you don't want these kind of situations. This is a girl from Nasik who has calcinosis at the wrong areas, shakal pe. Father is एव्हरी टाईम बरं तर होणार ना, बरं तर हे काढू नाही शकत का, इज अ शेतकरी, इज अ फार्मर. Muscles are all quiet. Child is growing nicely. Even this she has failed everything. Methotrexate, mycophenolate, cyclophosphamide, rituximab तो जेब की बाहर है. Cyclosporin भी फेल हो गया, tacrolimus भी फेल हो गया. Finally, I put her on tofacitinib, which is a JAK inhibitor beyond the scope for pediatricians. But after that, at least these lesions have started coalescing, which is the first sign that she will recover. देन आय हॅव टू एक्सप्लेन की तुम्ही शेतकरी आहात ना, मोदीजी काय शिकवलं, जमीन कसं आहे बघा. देर वॉज सम स्ट्रॅटेजी अबाउट असेसिंग द सॉईल क्वालिटी अँड देन पेरणी करा. आय टेल देम दॅट get the muscle enzymes quiet, get the inflammation quiet, then we'll get the surgeon to remove it. Removal is not the solution. You have to control the inflammation. So you don't want these kind of story, but this is a situation where the myositis antibodies will be helpful for giving you a reason why it has happened, and secondly intensifying the therapy. Please don't send it. 10,000 rupees for the 16 blot test that I told you. So this is just one more example. What's this child was referred to me as recurrent parotitis since age 3 years, and this the pediatrician thought is a dry eye, and he said मेरे को ये शोग्रेन लगता है, पैरोटिड भी है और ये ड्राई आइज भी है. इसको ड्राई आइज है क्या? And this child has had a history of, he's got a bad pneumonia at a young age, he's got tapped, rickets, contractures, rash, and this kind of, now we know, no, when you see ulcers on the elbows, what are you thinking of? Sorry? What are we discussing now? JDM, correct? So vasculopathy. Is this dry eye? What's this? Absolutely. This is a heliotrope, correct? So what's the diagnosis? JDM है कि शोग्रेन है? पैरोटिड भी आ रहा है ना, पैरोटिड क्यों आया उसको? हाँ, so mixed बोल सकते हैं, और you will call it undifferentiated and set him up for a ANA blot. And then you look at him, he's got the world's best. What is this? V for Vijay. Perfect. You can see the small laddu here, chotu sa niche. That was labeled as rickets, rachitic rosary. That's a calcinosis, dystrophic calcinosis. And then you look at his hands. What are these? This child has had these kind of things. He's met everyone from Chennai to Mumbai and everyone has made a mention. Some skin rash. He's got a contracture released because of a tight tendo Achilles. And just behind that so-called rachitic rosary he's got this also. So this is super bad dystrophic calcinosis. His muscle enzymes are bang normal. His ESR is 100. So remember, JDMs have normal ESRs generally. And then you send his ANA blot. He is Rho positive. So he's a bit of Sjogren. And you send a myositis panel because father sells MRI machines. I said more than that, your son needs a diagnosis. And his MRI is showing florid myositis. And he tests positive for an antibody called anti-MDA5. Remember, MDA5, MDA ka ulta is ADM. What is ADM is amyopathic dermatomyositis, where your muscle enzymes are normal, but you have florid myositis. And these are kids who will have bad pulmonary disease, hyperferritinemia, spontaneous pneumothorax. The look on all your faces is, पुढचा visit कधी आहे तुमचा? येणार मी परत. I don't want to give too many things into your system, but remember that crazy things can happen. I have 3 MDA5s from Nasik. One of them presented to the intensivist with a sudden spontaneous pneumothorax. And then I get the message in the common group and I, Parmanand is lucky. उसको भगवान इतना पेशेंट पे पेशेंट भेजता रहता है. अब pneumothorax भी वो स्टाफ ऑरियस करके चालू हो जाएगा. Right? And then one resident comes and says, सर ये आपके पेशेंट के टाइप का कुछ तो है उसको, दिस इज़ अ DNB रेसिडेंट एंड आई सी, चलो जाते हैं, देखा तो शी इज़ गॉट्रॉन्स, 6 महीने से उसको उठने में तकलीफ है, एंड देन सडनली शी जस्ट ब्लोज अ न्यूमोथोरैक्स. So she is straightforward amyopathic dermatomyositis, which and she tested positive for this. Her ferritin was 8,000. Very less you can do for the kid. But we could have saved her if you would have not missed the gotrons at least. So to a limit, genetics does have a role, but you shouldn't be missing out. Just have a proper look from head to toe. कुछ नहीं दिखा तो फोटोज निकाल के सोचो उसके बारे में, टाइम मिला तो, करेक्ट. So that's why the teamwork helps. I can't do what the intensivist does, but once my intensivist hands over the case, he doesn't mess with what I do. I don't mess with the ICD, YCD, but that's where, it's always good to discuss and take it forward. This was another last kid of this talk. What's this? What are you seeing now? Just answer this and we'll move. Is this normal fingers? Contractures dikh raha hai na? Very nice. I think my purpose is sorted as long as you don't forget what we learned. What else is seen? Gotrons. Perfect. You think this is normal? Possibly. But is the skin normal? Shiny, right? And what's here? So DDM, contracture, gotron, tight skin, तो scleroderma की myositis, so combo. So scleromyositis, again not very clever, जोड़ो दोनों जो भी अधिकता है, and she tested positive for an antibody called ANA blot में anti-PMSCL, which is polymyositis scleroderma. So again, not rocket science, you pick up the muscle and the gotrons and the skin and refer. Life is easy. Put her on methotrexate and she is happy. This was a pediatrician's niece. Marathon दौड़ के आई तो hip stiff हो गया. And then this is a 12-year-old female. What can a 12-year-old female have? Lupus. Polyarthritis. Excellent. So this girl's finger is normal. Contracture without stiffness and increased over 6 months. And in the same consulting room, she becomes Raynaud's. Is this Raynaud's phenomenon or is it Raynaud's disease? So what will you do? What's the diagnosis? There's a reason I am showing you the nose also. Even this is a slightly pointed nose. Perfect. How will you prove it? First thing you will write is what? CBCs etc. done. नहीं, टेस्ट क्या लिखेंगे? How will you confirm scleroderma? Perfect. Loudly. पहले ANA भेजो. ANA will come positive and then you send an ANA blot which will test for SCL70. Easy. So when you see Raynaud's phenomenon with these kinds, think that you will, and some kids are lucky, this is only the skin. This girl used to play professional tennis and the reason she came to me was tennis nahi khel sakta. See the leg, tight skin hai, and you can see what happens when you don't treat this for 1 year. This thing that started from the foot has gone upar all the way to the thighs. Only the skin. So when you have only the skin, it's called as a linear scleroderma. This is the worst thing that can happen. This is diffuse morphia or diffuse scleroderma. Same, and obviously there is a vasculitic element to it. So diffuse scleroderma, the previous one was localized or linear scleroderma. Hopefully we won't see many kids like this. This kid had come from Bihar to a medical college, was being treated as severe acute malnutrition, and the dermatologist first time they gave this Duncan's dirty dermatosis or terra firma forme dermatosis, which in simple Marathi translates to अंघोळ घेतली नाही आणि खूप घाण चिपकलेला आहे, इथाइल अल्कोहोल घालून पुसा आणि बरं होणार. But if you notice, अंघोळ घेतलं नाही तर इकडे का असं आहे, स्किन टाईट झालेलं आहे, जॉईंट्स डिफॉर्म झालेले आहे, पूर्ण तोंड उघडता येत नाही, अँड द सेम एल्बो with shiny skin and bad calcinosis, right? This is pansclerotic morphea. Very few case reports reported, but and usually life threatening. But if you diagnose this in this age, affording to bahut dur ki baat hai, but tocilizumab etc., we are learning many things. The key is to not mess around with malnutrition guidelines, but proper referral. And so the last slide on connective tissue. Suspect. How many of you know what's ANA and what's ANA blot? ANA भेजने का कि blot भेजने का? Blot भेजने का. ANA भेजने का. So what's the difference? What? So what's the difference? What's ANA blot? Correct. But what is different? And what do you infer from a blot? Correct. So ANA will tell you if my body is making antibody to the nucleus, and the blot will tell me which antigen in the nucleus is the ANA directed against. If it is Rho antigen, it is Sjogren. If it is La, it is Sjogren. If it is SCL70, it is scleroderma, so on and so forth. As a rule, अनअफोर्डिंग है तो सिर्फ ANA भेजो, या उल्टा सोचो कि ब्लॉट भेज दो, ANA आया नहीं आया फ़र्क नहीं पड़ता है. बट ANA नेगेटिव and the blot comes positive, you have to change the lab. Unless your ANA is positive, your blot should not be positive, right? So this I'll skip. So take home messages, we will, I think Dr. Atul can sum up in the end. Same story, so stop seeing, start looking, stop hearing, start listening. You may be allowed to snore once in a while. So we have 10 more minutes for vasculitis. I have a big collection of males for some reason. So as I said, girls can have HLA-B27, boys can have lupus. It's just that in fact Solapur has, many of them are from Solapur only, the male lupus patients. Yeah, and previously also we have, Dr. Ashutosh has sent me one male lupus with AIHA, E1 syndrome. I had been to Northeast, and Northeast mein it's rampant, SLE, Assam, Guwahati, Nagaland. And if you read literature, Asians, Chinese, Hispanics, etc. have bad lupus. And without sounding, racist, you think that the northeastern part of India would have some Asian genes. हर तीसरा बच्चा in their pediatric OPD is class 4 nephritis, class 3 nephritis. And the sad part is they have rituximab in-house, but they don't know how to use it. None of them are on MMFs and DMARDs, etc. This was my eye-opener when I was doing rhythm in Nagaland and Guwahati. Resource है लेकिन use करने को नहीं आता है, and diseases are also bad. So the idea is early pickup, you will help a lot of them, Okay, so the last 10 minutes of torture, we'll see how we can go. So vasculitis, no prizes. Inflammation of the blood vessels. Vasculopathy, you may have inflammation, but it's primarily the vessel wall is normal, but there is ischemia, right? We'll skip the statistics. For all practical purpose, the blood vessels are large, medium, small, right? We know that aorta and its major branches are large. Medium vessels are the renals and the main visceral GI arteries, etc. And the small vessels are intraparenchymal arterioles, venules, and capillaries. It's an umbrella term. By vasculitis, I am going to talk only about primary vasculitis. The secondary ones like post-infections, post-malignancies, post-autoimmune, etc., we will not discuss in details. I will skip the classification part of it. But if I ask you what are the classification of any vasculitis, you will call it large, medium, small, which is the adult classification. In children, we will add a word called predominantly. So predominantly large, predominantly medium, predominantly small. Means what? The large in a kid can overlap with medium. The medium may overlap with small. Which means, what's an example of a medium vessel vasculitis? Two cases. Two. And perfect. Large vessel, Takayasu. Small vessel, granulomatous, non-granulomatous. Granulomatous is Wegener's. HSP is non-granulomatous. Wegener's and Wegener's का भाई क्या है? Church-Strauss. Correct. The non-granulomatous most common is HSP. Perfect. When do I suspect vasculitis and why do I have this man? I'm wearing blue, not orange. My car is orange, but I don't have any political affiliations. When you see this man, what do you remember? The best thing? Roads. So like roads, you have blood vessels. Wherever there is a road, there is a highway, and most highways are good in the country, which means vasculitis is going to come from Kashmir to Kanyakumari. So all the experts or subspecialists can pick up vasculitis. So symptoms, etc., I will leave it for you to go home and revise. So anything from the brain to the kidney to the liver to the skin, etc., can probably have. So this is the list of all the symptoms: strokes, cranial nerves, hypertensive encephalopathies, claudication, blindness, deafness, hematuria, you name it, and it's there. Correct? And don't miss, this is the other situation where both of them will be high. Usually, you will never have a vasculitis with a Thanda, ESR and CRP. And this is the situation. Most of them will present with PO with either a rash or multi-system involvement, hypertension, high ESR, CRP. We will learn it through cases. So first thing is, you suspect vasculitis. Second is, how do I answer large hai ki medium hai ki small hai, right? So large vessel will typically come with A for absent pulses, B for bruise, C, you may have congestive cardiac failures like Takayasu, discrepant blood pressures, elevated BP. You can take a picture of this. A, B, C, D, E is very easy. So Takayasu is the most scary thing which can come with all of this. You know, when was the last time you put your finger on anyone's pulse? I don't think we have ever. Since pulse oximeter aa gaya, to pulse chala gaya. So, you know, but if you're not having any clues, it's a good story. What about a medium vessel? Abdominal pain. So renals, mesenterics will have abdominal pain. You will have blindness, claudication. You can have the infarcts like polyarthritis. I'll show you some pictures. The small vessel, you can't go wrong. HSP is your prototype image you carry. If not HSP, then at least you can start off by thinking it's a small vessel disease. And once you know it's it's large, medium or small, then you throw the labs. And again, most of them will have anemia, neutrophilic leukocytosis, thrombocytosis. You can have kidney involvement in the form of hematuria, pyuria in small vessel disease. High muscle enzymes can be seen in polyarthritis nodosa. You can have neuropathies in PAN, and then you can have secondary causes like lupus. We've seen, you know, macrophage activation could be the first presentation. We will leave that for some other day. So the first case is only Takayasu. The problem with Takayasu is there is a I am looking at the watch for you, 2.5 minutes. Pre-pulseless and pulseless. So just take a snap of this. Takayasu will be thought of in all of this. A, B, C, D, E, F, G, H. Right? And then you will not go wrong. The take-home message is, if you don't have any clue, and after today's lecture you start sending ESRs in an adolescent girl and it comes back as 120, you will suddenly see CRP क्या है, CRP नेगेटिव है, लेकिन बच्चे को कुछ भी नहीं है लूपस जैसे, तो फिंगर पे पल्स पे फिंगर डालना, सी इफ देर इज अ पल्स और डिस्क्रिपेंट पल्स, 4 limb blood pressure check करो, and then set her up for a imaging. As this girl I saw her after 1 year of fever on and off, vague symptoms, headache, backache, but weight loss of 5 kilos. And the pediatrician had sent blood tests 4 times with the ESR, and for no reason the ESR was 3 digits. And then she started having increasing backache. The pediatrician rang up the ortho. Ortho said उसको पक्का TB है, तो उसका इमेजिंग किया स्पाइन के लिए और फिर मेरे पास भेजा. तो मैं उसका पल्स देखा, बीपी चेक कर रहा है ओपीडी में, तो उसका वो द पीडियाट्रिशियन रैंग अप सेइंग अरे, एंड आई वाज गोइंग टू टेल हिम कि डू एन इमेजिंग फॉर टाकायासु. ही रैंग अप की टीबी के लिए हमने इमेजिंग किया, उसके सीटी में एओर्टो आर्थराइटिस आया है. So strange thing, but good for the kid that at least it got picked up. Take home message is, when you don't have any explanation, rule out Takayasu, because that pre-pulseless phase can be missed, and the median delay to diagnosis in the best developed world is up to 18 months. And 3-digit ESR causes, please remember these 4. And this was her image. This is spectacular but bad for the kid. You can see this aorta. It's almost become narrow, and you can see these small outpouchings, and she's got carotids which are stenotic, very bad disease. And this used to be our full stop point, but these days you actually document activity in the vessels by doing an FDG PET. FDG PET will pick up all angry. You can see the same aorta is all inflamed. It's picked up the dye nicely, and this can be reversed after treatment. So, because it is one condition where you can't predict if the girl is getting better or not, because there is no symptom. I can't keep doing imaging every month. So once in a year, you could probably end up doing this. I'll skip this for want of time. Take home message: unexplained strokes. Patient can come crashing with cardiac failure, blindness, congestive cardiac failures, hypertensive NSEP with non-specific fevers, fatigability, 3-digit ESRs. Remember absent pulse, BP discrepancy, CRP and ESR, and confirm with an imaging. Who was Takayasu? He was an ophthalmologist. So you don't forget to check the eyes. So medium vessels, I'll just show it through. This girl was my first pan come from Solapur. 9-year-old girl, and Dr. Vikram called me saying that I have a girl with fever for 6 weeks, and she had large and small joint pains, severe muscle pain, difficulty in climbing up, and I had been given a diagnosis of ARF, JRA, NSAIDs, etc. What's there in the CBC? Quickly. That's abnormal. Quick. Leukocyte, neutrophilic leukocytosis, ESR is high. She was admitted after 1 month with Dr. Vikram, and the history was very simple. Sorry? Yeah. That's coming slowly. But this was our first phone call. Hectic spikes, and the child is toxic, and severe tenderness, and blood pressures were high. And then he told me there is nasal regurgitation and she has a twang, and neuro opinion was sought and query GBS because she has weakness, she has a twang. It was suggestive of a neuropathy. And then, to just somewhat, I was in Pune actually, one of my Sushikshit Bekar days, without any OPD, and we started talking on the phone, and I said, aur batao. And then very diligently we talked for half an hour, and he gave me PUO in a sick child, systemic symptoms. So bones, muscle, joints, what can connect the 3 is blood vessels. Lack of blood vessel can cause all the 3 of them. Severe abdominal pain, mesenteric vasculitis, neuropathy and nasal twang. Again, neuropathy, with vasculitis is medium vessel disease and high markers. So definitely an indication for steroids. Most likely, I think we said let's do a Doppler to see if there is any medium vessel story. But multi-system involvement was there and we repeated everything. So you could see counts were increasing. I am happy, platelets high, counts high, ESR high, CRP high. So all, hyperinflammatory, multi-system. Muscle enzymes were also high. We said do a CT. I think this is polyarthritis nodosa. And the CT was normal. Abdominal vessels were absolutely normal. I said still give Solumedrol, and we gave Solumedrol. After the first dose of Solumedrol, I think I get a call again from Dr. Vikram that there are few nodules under the shin and the skin, and then it's been there for some time. And then there is also this fingertips which are looking a bit dark. And I just send the pictures. And then we did a USG Doppler of this. So this picked up, complete occlusion of distal, radial and ulnar vessels, if I remember correctly. So abdominal vessels were normal, but he had medium vessels can be affected everywhere. This was the picture, Have a look at this. Is this hand normal? After today, you will never call this a normal hand. No, what's this? Contracture अभी नहीं बोलने का, अभी vasculitis में है ना, हाँ है contracture, but what's causing it? I told you there was a neuropathy on an NCV also. So what's this? It's an ulnar claw, correct? So ulnar nerve. And what's this? Fingertip? It's ischemia, vasculitis. And what's all this? Livido reticularis. So you have subcutaneous nodules, which is erythema nodosum, livido, ischemia tips, and an ulnar claw or ulnar neuropathy. Everything starts to fall in place. This is, when you see this, the PGs, when you, anything in the shin area is what? Erythema nodosum, perfect. Erythema nodosum, idiopathic, streptococcal, EBV, mycoplasma, polyarthritis, TB, sarcoid, inflammatory bowel disease. Easy. And then what do we do with this child? We pulse her with Solumedrol. This is how she looked. Okay, wait. You will, this is when she first came to me. This girl is obscuring. Wait. Okay. Now, आता volume लागेल मला. So, happy or sick? Good pediatrician or bad pediatrician? तुम्हारा ही दोस्त है बाबा. Excellent pediatrician. No, he sent me all this. This is pre-COVID era. Telemedicine. Even, he was navigating, I was driving, God only knew what happened. But then, you use your brains. This is This is 1 month after Solumedrol and oral steroid. She comes to Bombay. You think she's normal still? What do you... She still has a nasal twang. She wanted to become a doctor, so I just put my stethoscope around her neck and she was happily talking. And after... Wait. So this girl can be quiet. And this is 6 months of cyclophosphamide, and this is after 6 months of cyclophosphamide. So this is absolutely cured. I'm not even using the word. You know, if we would not have talked, if we would not have made sense, Capre surname is a problem, that fingers would have, I think rickettsia is called Kan Kapya or something, no? This kid would have lost her fingers, but this girl was completely cured. We put her on cyclophosphamide, 2 years of methotrexate, and she's completely cured. Full recovery. She had one more flare about a year or two later, but I haven't heard from her ever since. So I assume that things are fine and she's cured. So PAN is one condition which can be completely cured. Bhunknara kutra ahe, generally चावत nahi, but you have to be very, very proactive. So in life, whenever you see such pictures, bad ischemia, gangrene, ESR 100, think of PAN. ESR 20, think of APLA. Antiphospholipids can cause ischemia with relatively normal markers. फोन आने लग गया लोगों का. अभी last slides. What's this? No wasting time. We are all experts. I want to do one exclusive Kawasaki CME for Solapur at some other time, because there are a lot of new things that have been happening, and I'm sure you might be seeing them. Don't want to rush, but this is Kawasaki. I will skip this. This is a very typical situation that I encounter because of the referral bias. But infantile KDs, please be very, 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 very careful. कुछ भी नहीं समझ में आया, fever आया infant को. What does this infant have? Bell's palsy. I have one more Bell's palsy who's admitted in Jupiter right now. It just has fever, red lips, goes to the wrong doctor, gets dexamethasone, subsides, comes back to the same pediatrician with a KD like rash. The pediatrician says, stop the steroids, come back and show me. Goes home, child starts having difficulty in swallowing, gets a deviation, goes to Wadia, sees a neurologist who says, घर जाओ, vacancy नहीं है, परसों आओ. They come back to Jupiter to the same pediatrician, and obviously everything is high, and the first thing we do is an echo, and the Z score is 14. And it is day 20 of illness and Z score of 14. So infantile Kawasaki, especially with facial palsies, CNS involvements, HLH, Kawasaki disease shock syndrome, please do not sit on only IVIG. You have to throw IVIG and steroids and or infliximab, because that little a giant aneurysm at the onset is just going to keep on increasing. So summary is just that, make a phone call to me. ऐसा कुछ दिखा तो. We will talk about this at length because I don't want to rush through it. So the take-home message is, have a high index of suspicion. Less than 1 year, no. Any fever, please put an echo and do a NT pro BNP, and the infant is the right age to see BCG reactivation. BCG reactivation does not happen in an 8-year-old with Kawasaki. It is that 1 year, 2-year-old fresh BCG है तो वो reactivate होता है. Time होता तो मैं पूछता, why does BCG reactivate in KD? Anyone who knows the answer? Answer is HSP. So heat shock proteins. So go home and Google it up. Okay. Most important line in this slide is what? Involve a pediatric rheumatologist early, especially the less age group ones, right? And these are all the situations where you might need help. Infancy, HLH, shock, the one who comes with torticollis, don't sit on this. Many of these kids will be getting ENT ka treatment, quinsy, whereas the problem, it could be a KD pharyngitis. So skip. I promise this is the last 15 slides. This is just for fun. What's this? Which is Kawasaki? This was the last month saga. इसमें से कुछ कुछ कावासाकी है, कुछ कुछ कावासाकी नहीं है. एंड वेयर आई वॉज कमिंग इज एवरी मैसेज ऑफ माइन इन द ग्रुप वॉज इग्नोर्ड रॉयली. हे तर असंच बोलत राहतो काहीतरी इज वॉट आय पॅराफ्रेज, बिकॉज द पीडियाट्रिशियन्स आर ऑल डिस्कसिंग स्कारलेट, ASO, अँटी DNA अँड कसं डायग्नोसिस करायचं, द्यायचं की नाही द्यायचं. अँड मैं बोलता था स्ट्रेप्टोकोकस इज माई फ्रेंड ऑल्सो. इफ यू आर सीइंग 100 लिप्स, एक तो KD निकलेगा, बिकॉज आई वॉज सीइंग KDs एट द सेम टाइम, बट माई KD वॉज वंस इन 20 days or 30 days. You were seeing 20-30 red lips every day. So I said, let's have a collage of this, Which one is KD? Take a guess. ये क्या है? HSP, right? So HSP, so what is common to red lips and me is not just KD. Streptococcus is a known trigger for HSPs, PAN, post-streptococcal, and Kawasaki to anyways used to be like कुंभ के मेले में खोए हुए भाई. Pre-antibiotic era, KD used to kill. Antibiotic आने के बाद KD used to do, Streptococcus does what the English did, Hindu-Muslim ladao type. So that's why they look similar, So we think as Streptococcus and Kawasaki are similar, but then you are right, this turned out to be KD. This also turned out to be KD, but received IVIG after 7 days, because that phase when you guys were seeing red lips, I was jobless. Every pediatrician was not at all, कुछ भी करो लेकिन विजय के पास मत भेजो. That, probably they were too busy to think, and then I did what I do, peace of mind के लिए मैं महाबलेश्वर गया. वहाँ पे स्ट्रॉबेरीज दिख रहे क्या कम से कम. I literally went to महाबलेश्वर and came back and this boy was sitting. We think it is Kawasaki. मैं बोला क्या चाहिए? रेड लिप्स है, यूनिलैटरल लिम्फ नोड है, पढ़ा लिखा माँ बाप was the only problem, because वो बिल्डअप हो गया तब तक, बायोफायर एंड EBV एंड स्कारलेट एंड माइकोप्लाज्मा, स्ट्रेट Kawasaki. What's this? Is this KD? Is this a strawberry? So the rule is the best strawberries often turn out to be scarlet. This is my experience, no evidence, but most of the scarlets will have a pakka strawberry. This kid was the most interesting kid. The pediatrician calls ऐसे lesions आए 3-4 दिन का fever. First it starts like this, then it becomes thoda blisteriform, then this happens. A few bulle, a few blisters. What's this? This is a 6-year-old boy. Short history, 7-8 day history. And fever is not a major problem. 2-3 days fever aaya, some cough in a 6-year-old. And the distribution of this rash is very unique. It's only the mucosa, hands and feet. What's this? Obvious thing is what? Steven Johnson's TENS, erythema multiforme, something like that. Yeah, so that's the clue. Some fluid comes and goes, pus nahi hai. And counts are about 4,000, 5,000 with cough. Very good thought. उसका कवर किया, so somewhere, I only remember 2 साल का बच्चा है तो स्ट्रेप्टोकोकस और स्टैफ सोचो, 5-6 साल का है तो क्या सोचो, स्कूल जाता है और टोपी पहनता है. What is टोपी in English? So what is caps? Community acquired pneumonia, no? तो mycoplasma. The pediatrician in Navi Mumbai hate me for sending mycoplasma. So IgM, sorry? Absolutely. So this IgM came very strongly positive, and then obviously a little bit of search of literature got you to this condition called mycoplasma induced rash and mucositis. It's a very, very specific condition, and all this needs is steroids. नो प्राइजेस फॉर गेसिंग, लेकिन सबको स्टेरॉयड नहीं देता है, ये साबित करके स्टेरॉयड दो, दैट्स फन, यू डॉक्यूमेंट एन इलनेस and it's not anamnestic because that pattern is very typical: lips, hands, feet, little bit of cough, and IgM positive. You throw azithromycin and steroids, complete recovery. For the parent and the pediatrician, it's a big headache because the child is not eating, child is hungry but can't eat, and you give a diagnosis, right? So this was just my rules that I had made for the red lips, So mostly we all know what red lips are, scarlet, adeno, EBV, Coxsackie, the list is never ending. The best strawberries that you see are often scarlet. Most or many of the scarlet fevers will have a sandpapery rash, but a sandpapery rash does not rule out KD. A few Kawasaki's can have sandpapery rash. Same, do not hunt for perilimbal sparing. While you have KDs with perilimbal sparing, you may have KDs without perilimbal sparing also. The bottom line is it should be non-chipku or non-purulent conjunctivitis. Remember, torticollis with red lips is an ominous sign for KD because the retropharyngeal space is loose collagen tissue. Any inflammatory edema will fill that retropharyngeal fluid. So if I have a torticollis with red lips, please do a CT scan. And if they say that there is RPE, retropharyngeal edema, please think it could be KD, correct? Unilateral nodes is the rule. Occasionally you can have bilateral also. The high risk ones are the ones I have highlighted. Less than 6 months KD, shock syndrome, HLH, please don't treat, you know what sterile pyuria is now, more than 10, more than 5. Dilated Z scores at diagnosis is often an indication for intensifying therapy. Should we stop or 3-4 more? Just photographs, no gyan. So this was a 10-year-old boy, fever, mucositis, rash for a week, and referred as suspected Kawasaki. Anand had sent, Bedekar Hospital. So abdominal pain, diarrhea, and biofire, everything was done. Very affording family, referred KD hai kya? You think it is KD? I mean, difficult to say. It could be anything, right? So, but then this boy was very, sleepy. He was not very active. And, when you see him, what is this? He is having some tremors or tremulous movements, right? So कुछ समझ में नहीं आता, go back to the history. काय झालं होतं का मागील 15 दिवसात, एका महिन्यामध्ये? So he has been diagnosed as partial seizures 1 month back, and his counts were 4,500, eosinophils were 15. So what's the cause? Which is the commonest? And I never thought this was an OSCE during my DNB, and I could not answer. और मैं सोचा ये ज़िंदगी में कभी काम आने वाला है क्या DNB के बाद? तो lamotrigine was the culprit. The question in the OSCE was the most common side effect of lamotrigine was, I wrote transaminitis, but it was Steven Johnson's dress, etc. And you read the literature, it's exactly when you double the dose, you start with a low dose, when you double up the dose, you start breaking into this idiosyncratic reaction. So strange things, what may look vasculitis could turn out to be something. So was it iatrogenic? Was it idiosyncratic? Bottom line is, the parents thought it was the औषधामुळे झालंय का, which is why I like the idiopathic, idiosyncratic, iatrogenic, idiotic. So we are idiots, but we should not be proving that we are idiots. So it's the most important slide. Whoever is walking out, please come back. Gaya bina sune hi chala gaya. This slide is for all of us. Who am I paying an obituary to? Is MISC. I think please do not diagnose MISC till we suddenly start seeing people dying of COVID again. I sometimes get a feeling that whatever MISCs you are diagnosing, you may be diagnosing, actually might be a Kawasaki, because we haven't seen any COVID only. And sometimes I think in the quest of making the child better, we are using COVID antibodies as a tool to give steroids. That's the biggest mistake that we will be doing. So no MISC, please. Are you seeing MISCs here? After this slide, you will say no only. But don't diagnose MISC, please. Because in the past, MISC was our short form for miscellaneous. In the COVID era, we all have seen enough of MISCs. अभी कोई MISC बोलेगा ना, you are probably grossly wrong. Sorry? It depends on who are those we. You know, I am talking on behalf of the Pediatric Rheumatology Society of India with some degree of responsibility, and the V's that you are talking about are WEs, not the V. WEs are the infectious doctors or infection specialists. See, the problem is how we know that MISCs usually come with a KD shock-like thing, myocarditis, fulminant manifestation. एक खाते पीते बच्चे का होठ लाल हो गया, you are not even calling it Kawasaki, but why are you calling it MISC? How many MISCs have you seen with giant aneurysms? Hardly any. I think the easiest way to understand is MISC was more myocarditis. M for MISC, M for myocarditis. K for Kawasaki, K for coronary socho, just for understanding. You know, Kawasaki is more coronaries, and I don't even want to discuss MISC. Don't diagnose MISC, please. And what bad habit COVID has taught us is the other three. You know, IL-6 भेजेगा अभी भी हम लोग सबका. So I told you IL-6 is expensive. CRP reflects IL-6. Fibrinogen is expensive. ESR reflects fibrinogen. And do not use D-dimers again. All D-dimers will tell you is it is some vessel injury. It's a prothrombotic state, right? So D-dimers, since time immemorial, rheumatologists knew that SOJI में high आता है, HSP में high आता है, any dengue में भेजा तो भी high आएगा. So don't send D-dimers. The only time I am sending IL-6 these days is NICU. If you have a fetal inflammatory response syndrome, some reversal, or the kid is having, something like a FIRS or MISN, as we may have called it during COVID times, send an IL-6. Please do not send COVID antibodies. Are they doing it in Solapur? Even now? The labs. So, you know, the problem is if you get a kid who is negative for COVID antibody from that era, most of us will come positive. How do I interpret it? So, don't send it. Okay, skip. Basically, ऐसा photo दिखा तो it is small vessel disease. Easy. This was just a kid. You can see bullous lesions in HSPs. An indication for starting steroids. Epididymoorchitis is seen in HSPs. Again, an indication for giving steroids. This is Dr. Atul's one-liner. HSP-like lesion without fever is HSP. With fever is rickettsia in this part of the city and wherever else. I had seen one kid who came to me from Ghatkopar. Looked very rickettsy, and I said, Solapurla जाऊन आले का? He said, Solapurलाच राहतो, घाटकोपरला आलो आम्ही. इकडे काही चावलं असेल का? बोला नाही, तिकडून खिशात बघा काहीतरी गोचिड घेऊन आला असाल तुम्ही काहीतरी. So clinical recognition is paramount. This kid had scleritis and ended up having, ANCA positive. Again, rare possibilities, but if you see scleritis, pulmo-renal is the usual, story. So get an eyes checked if you have such a problem. Eyes may give you a clue. And then obviously you find out a organ involvement and then do a reverse calculation, and you have CT which shows nodules, cavities, a bit of ILDs, and then your C ANCA will come strongly positive. These are extremely rare cases. This kid was actually a 11-year-old. This is like the post test for all of you. 100% I promise. Last kid. 11-year-old girl. What's the things you can think of? Morning stiffness. Came without an appointment with these hands. Polyarthritis. Can be RF negative also. Steroid खाया, अच्छा हो गया, दवा बंद किया, फिर ऐसे रैश लेकर आई वापस. And this time she came with a big thappi of medical college files. She was wheezing on 25 milligrams of steroids. Recurrent wheezing, and arthritis. And what vasculitis is large, medium, small? Small. And then she had 15 CBCs with 25% eosinophils, high platelets. So the new name for Scherk's is EGPA. Perfect. So, the patient tells you many things. It's just a matter of battery kab chamkegi, and document sinusitis, document pulmonary changes, and you document a P ANCA, and it comes positive. To take home message, large, medium, small. I say large vessel is silence is golden, means many of them will be very silent, very innocuous but badly progressive inside. You just have to have a high index of suspicion. Medium vessel, I say speech is silver, it will show up nicely. Infarcts, gangrene, hypertension, neuropathy. Small vessel is very easy. देख के ही समझ में आएगा. Self-revealing. If you didn't understand this slide, you can see this. Which is large, which is small, which is medium? Small, medium? Abhi clear hai na? Small vessel always makes a lot of noise and its diagnosis is very obvious. The medium ones are a bit difficult to understand, but it can be a bit of a googly. And the small ones, large ones are the most dangerous. They are very silent. You really can't read what is there unless you start imaging. No, iska photo mat lena please. I might get into trouble. I tried selling this slide in Srinagar and the Srinagar wala fellow was like, sir, if you don't mind, can we not use this slide? I was like, okay, I think I know where you're coming from. But I think this is one of the best way to remember, the worst ones are the large ones. Medium ones, if you hit hard, get better. And the small ones are like barking dogs, seldom bite. HSPs being point in case. Super. So this we have done. I thought I had 3 slides on steroids. है एनर्जी इम्पोर्टेंट है. इसके बाद तुम लोग नहीं बुलाएगा तो भी चलेगा मेरे को. The same slide, first time I used. Please say stop. चालू रखूँ, 3 ही slide है. The problem is this steroid is not my locum. 2 से की 10 से के 30 से. That has become a new headache for me. Can anyone explain to me what is 2 से देना कि 10 से देना कि 30 से देना? Or it's the same कि oral prednisolone देना? And it's the same problem, my enemy. He will always call कि वो ठीक है 2 से कि 10 से के ठीक से. So the first tip is don't go to practice without ratifying this chart. Each one of us has to know steroid conversion chart. So 0.75 of Dexa. So remember steroids, short acting, medium acting, long acting. Long acting is Dexa, half-life more than 72 hours. Medium acting is methylpred, deflazacort. Short acting is efcorlin, right? And the equivalent dose is easy. Dexa yaad rakhna 0.75 mg. The medium acting is easy, 4, 5, 6. 4 of methylpred equals 5 of pred equals 6 of deflazacort. I haven't used deflazacort here because we keep deflazacort for the Duchenne's. But 4, 5, 6 yaad rakhega. And F-colin is 20, hydrocort. This is step number 1. So it will help you when you are switching or someone who's not in a condition to take oral steroids, right? Step number 2, so 0.75 of DEXA is 4, 5, 6 and 20. The second thing is there is absolutely no difference between 2 ki, 10 ki, 30. If you use a 30 kg बच्चू as an example, 2 mg per kg चालू किया तो 60 mg हो गया. Okay, is that a high dose or a low dose? Sorry? High dose, correct. Same 2 mg per kg MPS, by my conversion 60 mg of methylpred becomes 75 mg of prednisolone. Is it low dose, high, higher? Higher. If I use 10 say MPS, it becomes 375 mg of oral pred equivalent. This is 10 mg per kg almost. And if you are pulsing, it is 1125. So like Bata Chappal, don't go by absolute numbers. The worry is immunosuppression, and this conversion tells you that all the doses are equally, if not more and more and more immunosuppressive. So it really doesn't make a difference if you use 2 or 10 or 30. Then how do I decide? Go back to physiology. Numbers don't matter. How rapidly do you want the steroid to work is the thing which is important. What do I mean by that? So when you see genetic mechanism how steroids work, we all know genomic and non-genomic. So the genomic mechanism is the prednisolone or MPS enters the nucleus, starts affecting the transcription and translation, and then starts working slowly. So that is genomic. It takes time, but it works good. That's your oral dose that we use, 1 mg, 2 mg. The non-genomic is the pulsing dose. It doesn't need to wait till it reaches the nucleus. By various mechanisms, even before it enters and hits the nucleus, it binds to membrane-bound receptors and it starts working fast. So, agar koi patient is dying, I will not use 2 mg or 1 mg oral. I will probably pulse him with 30 mg per kg because it is rapid acting, and remember rapid exiting also. That 1125 mg of MPS sounds very high, but it will get out also because it is moderate acting versus a dexamethasone which will work long, but it will take a lot of time to start working, right? So if I am in a crisis, it's a pulse dose of 30 mg per kg. If I am not very sure if it is septic shock or Kawasaki shock, I will probably keep him on 10 mg per kg till the culture reports come back either ways. If it's a small newborn in an NICU who is, I am really worried that steroid will harm, then 2 mg per kg is good enough. Send all the cultures, comes negative, then you may just take a call to either escalate or de-escalate. If a lupus patient comes to you with a pneumonia and shock, how do you know it's lupus pneumonia ki it is a streptococcal pneumonia? CRP and ESR. CRP 200, it is a bacterial pneumonia because lupus is a CRP negative condition, correct? You will need that little bit of steroid to keep her hemodynamics and lupus under control. That's the time when I may give a low dose of steroid and continue antibiotics. So 2 ki, 10 ki, 30 is very, very situation dependent. The whole idea is we have to reach 7.5 mg in all of these rheumat patients by the time you reach 6 months, right? So genomic and non-genomic action is important. इसको बंद करते हैं, ये ट्रेड सीक्रेट है. The kidney is angry only because I say no to 2 milligram per kg. Leave the 2 milligram per kg dose to the nephrologists for nephrotics. Most of the rheumatology patients, once you pulse solumetrol, even a 1 milligram per kg is a good enough dose. Idea is maintain that dose till you get remission, and then you start slowing down. I'm seriously looking like a BJP person, no? Sorry for that. This is a take-home message, I am going to take peanut chutney and red chilies for me. You take CRP and ESR home for writing it tomorrow. टाइम पास के लिए तो चालू करना लिखने को, कुछ आएगा नहीं. दोनों नॉर्मल आ गया तो कॉन्फिडेंटली बोल सकता है बच्चेला वायरल आहे. बिकॉज इवन वायरस बोलने को भी डर लगता है ना अभी आजकल. तो कोरोना तर नाही आहे ना, असू शकते. बट देन if both are normal, you are breathing happy. This is my double engine, CRP and ESR. You have been the best audience. शक्ल बहुत गंदा बना रहा है लेकिन मुंह नहीं खोला. I am so happy. This is the longest I have talked, but lunch break के वजह से late हुआ, so we are done reasonably well. Recognize the pattern. Perfect. Vijay, and so you see a joint, you will remember Vijay. When you see Vijay, you will remember Amitabh. Now the most difficult question. Please name all the movies clockwise. What is this? Which movie is this? This? Possibly Sharabi, but more likely, hints is we are best friends. What are best friends in Hindi? Friendship is called Dostana. Very nice. This is a googly. What is this? This is also Shahenshah. Correct. The Din ka avatar and Raat ka avatar. What is this? What is his age in this movie? डायलॉग है ना, 36 घंटा, 36 साल 15 घंटे 3 महीना और ये चौथा मिनट. This is maybe this is dawn. Diwar करके. What is this? What is this? काला पत्थर. And this is? How do you know all of this? Because कौन सा ये डॉन है, ये तो हमको पता है ना अभी. Gracefully retired. So why do we know all of this better than the back of our hand? Is we've been seeing this again and again and again and again. So I think I will leave this presentation here. Keep seeing this again and again का ज़रूरत नहीं है. Whenever you have a fight with your spouse or your kids are annoyingly, बच्चे पढ़ नहीं रहे तो खुद पढ़ाई करके set an example. Keep seeing this. क्या क्या बोला था remember करो, and I think revisit. It's not as difficult as it seems like. Super. Thank you very much.
Hello. Thank you very much, sir. Now I request Dr. Atul sir to sum up.
Good afternoon. I think Vijay, you have given a lot of take-home messages. So I think there should not be, have another take-home messages. Basically, we had a very wonderful time today morning. And you made this a difficult topic very simple, and that is the quality of a good academician or a person who knows subject thoroughly and a very good teacher. So big round of applause for Vijay. It's always pleasure to listen to your talks, and because basically your talks contains lot of clues, lot of clinical material, no tables, no graphs, no studies and all these things, and takeaway messages are always there. and talk is always a lively talk. I have prepared one module, and Vijay was one of the part that hit the bullseye module, and which was very popular. Last 3 years, we conducted more than 40 places in all over India, and he prepared the rheumatology module in that. Probably this year also we are planning new module for this year. So just take home messages. I am just going to ask you the things. A young age female, large joints, oligo. Less than 4 joints is oligo, more than 4 joints is a poly. So it is what? ANA positive oligos. A young age female, large and small joints, oligo, what it is called? Oligo extended, large and small joint involved. Adolescent female with bilateral symmetrical large and small joint is poly, right? Adolescent male, large joint below the umbilicus, sacroilitis, and with involvement of Enthesitis-related arthritis is HLA B27. A child presenting with the high PO, rash, hepatosplenomegaly, serositis, arthritis, anemia, leukocytosis, thrombocytosis, high ferritin, what it be? Okay. If child is sick, definitely one should think of a macrophage HLH, and one should do ferritin. Not only ferritin, the message is what is important. What we have to do? Ferritin, fibrinogen, triglyceride. Okay. Vijay, are you happy with that? Yeah, LDH will. Full HLH mass workup is important at this time. Unexplained fever without focus with constitutional features, headache, CCF, pulses are weak, dispersency, Takayasu, yeah. 1 to 6 year, winter, fever plus mucositis, red eyes, red tongue, Kawasaki. Fever, hypertension, infarcts, neuropathy, dactyl, some pan, okay. 2 to 7 year male, explosive onset purpura on lower limbs, pain in abdomen, joint swelling, HS purpura. Anasarca, eyelid swelling, gatron pupils, he has shown many pictures with heliotropes, is JDM. 11-year-old female with constitutional symptoms, pan or bicytopenia, high ESR with low CRP, and palatal ulcer. So it's very simple, I think. So Vijay had made the rheumatology really simple, but it is like we have to keep in touch with, as he said. And we pediatricians are always busy with our routine OPDs like fever, cough, cold, scarlet fever, hepatitis, dengue, and all these things. And these cases comes in 15 days or in a month. And sometimes these patients comes in a very critical situation also, especially mass. And sometimes KD patients can come in a very sick condition. So many times I call him and trouble him many a times. Yeah.
जो भी खुफिया cases goes to him, and he's got 3 people and a whiteboard. You tell kya hai, you tell kya hai, you tell kya hai, and it starts with a symptom and he makes one khufia diagnosis in the end. It's quite interesting the way he does medicine. It's one way of doing things. I'm not totally a house, but I don't carry a stethoscope or go to the patient, nor do I talk with zombies or dead bodies and have lunch with the so-called dead bodies. But it's good fun, and I just want the pediatrician to be the antigen presenting cell, pick up the right cases, send it across to me, let me process it, and then life it sorts out. It's not too difficult. As I said, I don't have infections and malignancies to think of. रूमैट है कि नहीं है रूल आउट कर देना. बिना पेशेंट देख के सीबीसी देखो, अरे इसको तो सीआरपी नेगेटिव है, अरे इसको ईएसआर हाई है. 3 दिन का हिस्ट्री में लूपस मत बनाना क्योंकि मैंने बोला था. बट 15 दिन में अगर ऐसा कुछ आया, दिस आर स्टैंडर्ड पैकेजेस. सो व्हाट्सएप भेज दो, इजी.
Okay. Thank you. Thank you very much.
Thank you, Atul sir. Thank you, Vijay sir. Thank you for an informative talk, and I'd like to thank all the IAPNs from Solapur and outside Solapur who have attended, and all the delegates, and thank you for the sponsors also. And before going, we'll click a group photo and then we'll disperse. So let's do that.
This whole today's CME, it will be on YouTube, IAP's YouTube link. It will be uploaded tomorrow or day after tomorrow. And also you have given MMC 2 points for today's CME. So keeping the patients had paid you 2 points of MMC. Thank you so much.